Good morning. I'm Senator Brennan, Chairman Brennan. I'm the new Chairman Barlow, and we're going to go ahead and bring this meeting to order. Joint Labor, Health, and Social Services Committee on October 16th, and we can go ahead and take roll.
Senator Crum.
He is here on Zoom.
Present.
This morning.
Senator Hutchings.
Here.
Senator Scott. Senator Steinmetz.
Here.
Representative Klauston.
Here.
Representative Gugemus.
Here.
Representative Heft.
Here.
Representative McCann.
Here.
Representative Ottman.
Here.
Representative Thayer. Here. Representative Wasserberger.
Here.
Representative Yen.
Here.
Co-Chairman Rodriguez Williams.
Here.
Co-Chairman Brennan.
Here.
You have a quorum.
All right. Just a few reminders. If you want to silence your cell phones, if you have not done that, please do so. We won't go all through all of the decorum stuff, but just, a few reminders to adjust the chair and to be cordial. And then I think our next thing is approval of the minutes from the last meeting.
Madam Chair, I'll make a motion to approve the minutes.
Madam Chair, I second.
All right, we have a motion and a second. All in favor, say aye.
Aye.
All right, those have been approved. So the first thing that we have on our agenda this morning is maternity care and the maternal deserts. And I believe we were going to start with the Wyoming Department of Health. Good morning.
Good morning,
Welcome.
Madam Chairman. Good morning, Madam Co-Chair, members of the committee. My name is Franz Fuchs, Deputy Director of the Wyoming Department of Health. Madam Chairman, we had a presentation in June for you all. We're happy to take any questions that are follow-ups on that presentation, but we didn't have any additional materials for you. We're just here to answer any questions you might have, but understand you have a lot of bills and memos you'd like to get to. So.
Anybody have any questions for the Department of Health? Representative Yen.
Thank you, Madam Chairman. Franz, can you talk about I think we read in the news that Platte County lost their labor and delivery services. Can you talk about the context around that and why it went away maybe? And I'm sure we'll get the hospital association at some point, but anything that you know around that?
Madam Chairman, Representative Yin, we don't know any specifics as to that particular decision. I would generally speculate that there's a couple general themes that have come out of this. One is that labor and delivery is not it's kind of a loss leader. It's kind of a cost that a lot of hospitals incur that doesn't make a lot of money. And so there are financial reasons why hospitals and business reasons why hospitals will choose to discontinue that service line. I know in Platte County in particular, my understanding is a lot of births were, generally going to, up north to Converse County or down to Cheyenne. So there may have been sort of a decrease in births there. It was generally low level. In our presentation, we have some data there that shows the births by hospital, but not particularly, lower than other smaller hospitals that still maintain labor and delivery. So, but I don't want to speculate to specific reasons why that hospital chose to discontinue that service. Those are general themes we observed during the past couple years.
Representative Ottman.
Thank you, Madam Co-Chair. Good morning. I do have a couple of questions. One, can you talk about insurance for doctors for maternal care? Number two, could you kind of talk with me? In Riverton, we're having a new hospital go in, and I'm hearing that it's critical access so that they could get, anyway, part of that. So that's kind of up there. And then also with the traveling around the state about the 500 million or whatever that Wyoming is possible to get, that has to be an application through the executive branch. And so just a little bit on that, if you could update us. Thank you.
Sure, Madam Chairman, Representative Ottman. So your first question was about, I'm assuming medical malpractice liability for physicians for OB/GYN. I know that's a concern. I think, the hospital's ability to retain providers, whether they are local OB/GYNs or obstetric providers or family practice medicine docs, they, typically you want at least 3 in the community to maintain the coverage. You need 24/7. We never know when emergencies might happen, or obviously babies don't usually come as scheduled. So you usually need, 3 to kind of maintain coverage. And so that's kind of the threshold at which if you get below that, it really becomes more difficult to maintain those services. I know malpractice coverage is an issue, certainly on the cost side. I don't know if it's the driving factor. I think I would defer to the associations here that could speak more to that. I do know there's other, certain entities like, for example, federally qualified health centers do have federal tort claims protection that can help with that. But again, I'm not sure the interplay as far as how many FQHCs are involved in the obstetric business and how interlinked they are with hospitals. That was your first question, my second question. Refresh my memory on the second question. Sorry, Madam Chair.
Madam Co-Chair.
Go ahead.
Yes, with the critical access, just the differentiation between hospitals or why that could be a good thing for the hospital that's going in there. It's smaller and things. Thank you.
Yes, ma'am. Madam Chairman, Representative Ottman. So there's generally 2 types of acute care hospitals. The larger hospitals tend to be, we call them PPS or prospective payment system. And so what that means is for any given inpatient episode, for example, you stay in a hospital for a certain period of time, Medicare will pay them a sort of flat amount of money based on the diagnosis and, what essentially that's sort of an average of what that costs across the country. So they get sort of a flat rate for an inpatient stay, no matter how long it is or what resources are used in that. So that's why it's called prospective. So the bigger hospitals are typically on that, that kind of payment methodology. The smaller hospitals, if you're a critical access hospital, Medicare will reimburse 101% of allowable costs. So that's a real big deal because when you have low patient volumes and you have to maintain a certain amount of capacity in that hospital, being able to cover those Medicare allowable costs at 101% makes up a lot of revenue compared to what they would receive if they got a flat rate per episode or per stay. So it really makes a big difference for the financial stability of the hospital. Generally speaking, critical access hospitals have to have a limited number of beds, so they have to be relatively small, and they have to be, generally speaking, 35 miles away from another hospital. So they have to be the only hospital within a certain geographic radius. And I think the situation in Riverton is somewhat complex because you have obviously a hospital that's primarily based in Riverton, the existing one, but they have a satellite campus in Lander that is actually kind of their main, facility. And then you have this new hospital in Riverton that's, pretty close to the existing hospital. So that would complicate getting critical access designation. I think it would, unless there are a couple exceptions there. So for example, if the facility is tribally owned, then that 35-mile limit may not apply. I don't know the plans of that hospital, but my understanding generally of the process is they have to be licensed as and enter into Medicare participation as a PPS hospital first, and then they can convert to critical access hospital shortly thereafter. And that's what's happening in Sublette County and Saratoga with those 2 hospitals that are converting. They're in the process right now of getting that PPS designation, and then they'll get that critical access hospital licensure afterwards. So Madam Chair, I'm happy to pause there and see if there's any follow-ups, or I can get to your third question. Okay. So Madam Chair, on your third question, rural health transformation, the short answer is yes, we have an application that is due to CMS by November 5th. It's a very short turnaround, very short timeline. We are working on that application at the moment. We hope to have a draft to the governor's office. He's ultimately going to, review and approve that, whether we submit it or not. And that we want to have a draft to him by the end of this month, so he has enough time to review it. But it is a very, very short turnaround, and a fairly demanding lift for us, but we will definitely get it done.
Thank you, Madam Co-Chair. Just to follow up with that, I know when I spoke with, and I believe it was you, we had a conversation. There wasn't a lot of individual response. It was more of bureaus or agencies or things like that. Did you see any more of just the regular public participation in that?
Madam Chairman, Representative Ottman, it was definitely a lot of providers, a lot of associations show up to the public meetings. There were a lot of, I would say about the same, that it didn't change too much. There were certainly interested members of the public. I think where the public participation is a lot greater is what we did is, let me just step back. We took the feedback from all those public meetings. So we had about 11 of those, and we sort of consolidated a list of 33 themes or priorities that we heard. So for example, the importance of sustaining local rural hospitals as being a sort of a distinct theme, or primary care, access to primary care is a distinct theme, or access to labor and delivery. So there's a whole host of, 33 of these different priorities that we sort of consolidated and gathered. And we certainly have an agenda item tomorrow to talk in detail about that if you like. But we did put out a public survey, and we have about 1,300 responses for that. So we are allowing the public to kind of rank those now. So, that's been helpful, I think, and it gives people a voice as far as determining the relative weight of those priorities.
Yep, Chairman.
My
No shot.
question is, can you refresh our memory? You gave us some criteria as to what adequate OB services was at the start of your talk. How many communities in the state meet that standard of having the adequate?
Madam Chairman, Senator Scott, so we had a map, and I think it's in your LSO materials, they reproduced it, where we define a maternity desert in sort of 3 different categories. So we have the first categories we call long-standing maternity deserts, and those are areas where people have never really had maternity access, right? There's the people who move there would never have expected to, be able to give birth at the local hospital. And those are places, the northeast corner of the state, so Crook County, Weston County, Niobrara County, Bighorn County, Sublette County have been the long-standing deserts. We then have a category called new maternity deserts, and these are areas where we've had in the past labor and delivery services, but they've been discontinued. And those communities include, so the first one was Riverton, which stopped in 2018. We have Carbon County, which I believe was 2020, 2022-ish. Kemmer, so South Lincoln County, also around the same time period. And then more recently, Evanston, so Uinta County was last year, or late last year, and just last month, Platte County joined that list. And then our final category we calling warning, I guess, where we see births declining. And so Lander is one of those areas where the births in that hospital have been declining pretty sharply over the past couple of years. A lot of the moms seem to be going to Thermopolis, of all places, to give birth. So the births have ticked up in Hot Springs County there. But that's an area where, with declining births, that's kind of a little bit of a bellwether as far as what may be ahead. And so hopefully, Mr. Chairman, that Senator Scott, that it hopefully answers your question as far as which communities might be most affected. But I would just add that our criteria are fairly basic. It's whether or not there's a hospital that can do any, basic kind of delivery. It's not, obviously we have no, we only have 2 NICUs in the state. We have no level 3 NICU that you have to go out of state for the really complex, premature births. So there's a whole other criteria of more complex births that we're not including in that definition.
Any other Representative Yen?
Madam Chairman again, Franz, thank you. So the idea of declining births possibly being a bellwether, is that, what would your hypothesis for that be? Would it be demographic changes in Wyoming? Would it be people are just choosing to have births elsewhere? What can you give me some thoughts or ideas of why that would be the case?
Madam Chairman, Representative Yin, my hypothesis, one, we do have a declining birth rate generally, so you do see births declining across the state in every county. This is my second thought would be certain counties and hospitals have really invested in, so for example, Thermopolis does have a family medicine residency rural training track program. So they have a lot of family care docs, family medicine docs, and that I think has really helped provide that level of OB care in that particular community. Whereas Lander, my understanding is that there's been a lot of retirements for lately in that practice, and maybe not as many providers coming in to fill those shoes. I know the hospital in Thermopolis also made significant capital investments recently, and maybe it's a nicer facility, but we have seen births significantly increase there for what it's worth. And I think my speculation would be those two, factors are probably responsible.
Representative Costin.
Thank you, Madam Chair. Thank you for being here this morning. Just, can you refresh us on which providers in Wyoming does Medicaid reimburse for deliveries?
Madam Chair, Representative Clausen. So I do have, I'm sorry, I should have introduced him earlier. Jesse Springer, our Senior Administrator for Medicaid and our Medicaid State Agent, and I'd be happy to throw him under the bus for that question.
Madam Chair, Representative Clauston. So we would reimburse OBs. So what you would traditionally think of as delivering, but a good number of babies in Wyoming are delivered by family docs. So they just have those extra certifications. So really, they're all paid the same. We don't have a difference there. We also cover certified nurse midwives and midwives. So there is a wide choice of how to have a baby delivered, whatever the woman chooses. Different settings there. So, if you're having a midwife, a certified nurse midwife, you're likely having a home birth or possibly at a birthing center, which we currently don't cover, which is one of your bills today. But generally, most babies in Wyoming are born at a hospital and delivered by a OB or family practice physician.
Thank you, Madam Chair. So as a follow-up question, is there a path for advanced nurse practitioners to be able to deliver babies and being reimbursed for that?
Madam Chairman, Representative Clauston, what we're following is generally scope of practice. So these aren't reimbursement issues. So whatever is the max scope of practice in Wyoming, Wyoming Medicaid's generally following that. If it's allowed by state law for scope of practice among a wide array of providers, we're generally allowing those services to be done by those practitioners. So if it is allowed by scope of practice, it could be, but I don't believe. Well, let me think about that. I would have to think about that and get an answer to you later if that is currently covered as of today. Sorry.
That one I can't answer.
Okay.
So your advanced nurse practitioner that can deliver babies is your nurse midwife. And that is a different path for getting a nurse practitioner degree than, I shouldn't say different path. It's just a different, you can have like your primary type nurse practitioner, general, just nurse practitioner, or you can go into nurse practitioner with specialty in nurse midwifery. Those are the ones that could deliver babies. You're just general family practice nurse practitioner wouldn't be trained in any of that type of a thing. And because they do reimburse nurse midwives, it is reimbursable. And that's a different type of training than just midwifery training. Yeah, there were different paths. Senator Scott.
Madam Chairman, we obviously compete for medical personnel with all the other states. Is there nationally a shortage of obstetricians and people who can deliver babies? Are we suffering because we aren't paying them enough compared to other states, or because our legal climate is unfriendly compared to other states? How do we stack up against the rest of the states in this area?
Madam Chairman, Senator Scott. Madam Chairman, Senator Scott. I think generally speaking, again, a lot of the salaries of physicians, I think are fairly comparable, if not higher than the national average. I think, physicians to come to Wyoming, particularly to, some of the more rural parts of Wyoming, there is a premium that is paid for that, and as far as salary goes. Obviously, we don't control that from the state level. I think, broadly speaking, the biggest problem for Wyoming, and particularly the smaller parts, is a volume issue, right? If you only can deliver a certain number of births, how do you pay for that practice? How do you pay for all the support staff you need? Having the ability to have labor and delivery is a fixed cost. You have to have it just like an ER. You have to have it ready to go. You have to have people on call at any given time. And if you just don't have the volume, one, it's hard to pay for it, and two, the quality, right? You have to deliver a certain number of bursts to maintain proficiency, and that can also suffer. So I think the volume cost issue is probably the biggest single problem that we face as a state, and that's just something that's just fairly inflexible.
Any further questions? Representative Clouston.
Thank you, Madam Chair. One more follow-up question. I had understanding, is Wyoming part of a group of at least rural states looking at this as a group? I felt like there was maybe some kind of coalition of states that were trying to also tackle this besides just Wyoming itself.
Madam Chairman, Representative Clouston, we're part of a maternity desert work group through NASHP. It's a National Association of State Health Policy. So we applied for that group and we were accepted into, it was very competitive. I think 30 states applied and we're one of about 10 states that were accepted into that. So we're basically preparing strategies, sharing our approaches with the other states in that work group. There's a lot of good ideas from other states of kind of how to address this with community health workers, doulas. Some states are doing that. Different strategies towards hospital sustainability, liability, a lot of things that are being talked about by this committee.
Any further questions for the Department of Health? All right. All right, Senator Steinmetz.
Thank you, Madam Chairman, and congratulations.
Thank you.
I just have a question as far as, I'm looking at the report again, but how much of this is attributed to people traveling for more specialized care for, for example, where we see some long-standing deserts and then we see some new and some warnings. In the warning area in the north eastern side of the state, people are probably traveling to Rapid City or other places. I know in Torrington, we have a lot of people that go to Denver or to Scotts Bluff, all of those types of things. And so how much of this is really just society changing and their habits of how they want their healthcare delivered and more specialized treatment? Can you quantify that at all? Thank you.
Madam Chairman, Senator Steinmetz, I don't have a good answer for that. I think just a couple things. There is in our briefing materials, if you look at the birth trends, most of the declines are fairly slow, and I think we attribute that to just the declining birth rate generally for demographic reasons. We do hear anecdotes about whether it's private insurers or other payers that are steering patients out of state, but those are just anecdotes. We don't have any solid data to say. For example, in your neck of the woods, the number of births has remained pretty consistent around 6 per month and pretty flat since back to 2016. So there's been no real significant change we've observed in births in Torrington, for example. I would say unlike, for example, elective surgeries, complications with births are are not, are probably what drives the specialty use of care. And we haven't seen any data that those are complications are increasing or low birth weights are increasing, for example. So I would say trends are fairly stable except for that declining birth rate. But we do hear anecdotes from time to time of, mothers, for example, in Evanston, being incentivized to go to Utah as opposed to giving birth at the local hospital or choosing to go there for whatever reason. The main shift that we've seen is kind of what I mentioned is the, aside from the turnoffs of the labor and delivery units, has been the shift from a volume from Lander to Hot Springs. That's been the most discernible trend we've seen so far.
Any further questions? Okay, thank you. Next we have I think a short little presentation from the Wyoming Primary Care Association. Welcome, thank you for being here. If you guys would state your names for the record and then you can proceed.
Good morning, Chairman and committee members. My name is Jen Davis. I'm the Executive Director of the Wyoming Primary Care Association. And with me today, I have a graduate student who is going to be presenting some of his research to all of you. This is his first time presenting and first time in front of the committee. So if you would kindly help him out in this process as we go along today. His name is Andrew Corbine, and I'm going to turn it over to him for his presentation.
Madam Chair, members of the committee, my name is Andrew Corbine. I'm a Master's of Public Administration student at the University of Colorado Denver School of Public Affairs. And I'm completing my capstone with the Wyoming Primary Care Association, specifically focused on maternal care deserts and what Wyoming federally qualified health centers are doing to help bridge the gap. In addition to this, I've also been a social worker here in Cheyenne for the past 3 years. A little bit of background on risk factors experienced. One thing that I noticed in my literature review during my research is that maternal care patients started an uphill battle just for the place that they live. Risk factors increase for rural maternal care patients. When comparing them to urban patients, rural maternal care patients experience higher ICU admission rates and mortality rates. In addition to this, rural counties experiencing hospital and OB facility closures saw an increase to preterm birth rates. Also, increased distance and travel time for patients to OB/GYN care correlate to increases in more C-section or cesarean deliveries, severe maternal morbidity, preterm birth, and gestational diabetes. Above all, rural patients are less likely to receive higher quality care than their urban and urban adjacent counterparts. This is due to less access to comprehensive care, especially in low volume and low resourced hospitals. Also, there's the lack of OB specialists, emergency response resources, and proximity to hospitals with capacity for more critical care needs. As you may already be aware, in Wyoming, 11 of 23 counties had no practicing OB/GYN provider as of 2024. Regarding health insurance status, in 2023, 14% of birthing age women 18 to 49 had no health insurance. When focused on those specifically underneath 200% of the federal poverty level, that lack of insurance increased to 23%. Finally, in 2019, based on a report from the Wyoming Department of Health on a survey they conducted of the 2019 birth cohort, 31.8% of the births were below 100% of the federal poverty level. Overall, with this literature review, found that the demonstrated and primary focus was clinical service connection, although it's important to note that there are other key mechanisms, including social support, care frequency, education, self-efficacy, and positive reinforcement, all of which combine to ensure well-rounded care for our maternal care patients. Next, I want to touch base on the outlook for the Wyoming Primary Care Association and Wyoming's federally qualified health centers. To start with this project, I've conducted a qualitative interview to get perspectives of the maternal care landscape for providers and social workers and community health workers throughout the state. From the social worker and community health worker perspective, found common themes of housing affordability and instability, lack of transportation, lack of healthcare options for specialty care, and an overall financial resource strain experienced, especially during the third trimester, during labor and delivery, as well as postpartum. From the healthcare providers' perspectives at FQHCs, had themes arising of lack of providers, accessing adequate maternal care concerns, care gaps, especially for uninsured patients and those that don't qualify for Medicaid, and travel distance for accessing care, especially for uninsured patients. There were reports in those interviews of patients traveling anywhere from 30 to 90 minutes from their home to access federally qualified health centers that had maternal care capacity because it might have been their only option. Nationally, federally qualified health centers are estimated to provide care for 17% of the women giving birth in 2021. And in 2024, FQHCs provided care to 7 million birthing age women in the United States. After the literature review, I found some common themes arising of what other states are doing to attempt to bridge gaps in these rural care deserts. The first of which is mobile maternal health care and expanding telehealth availability, sometimes in collaboration. I provided some examples that were received from peer-reviewed articles, first of which being Southeast Ohio. There they focused on maternal care deserts in high vulnerability communities, and they provided care to 54 patients in a 6-month period back in 2022. 61% of the patients served had some form of public insurance, and 8% were uninsured. While outcomes were not tracked, there were limited positive results received, and the expectation is that the continuance of this program will have positive results on maternal care access in rural areas. Another example is in southern Minnesota. While this one did not specifically focus on maternal care, it was focused on rural health for isolated communities with providing specialist care access via telehealth while still having a staffed mobile unit for that physical presence. 45% of those appointments were from communities outside where the mobile clinics were, and those mobile clinics were stationed in communities that had a population of less than 3,000. This was a collaboration with the Mayo Clinic, and this provides an opportunity to connect people with primary care and other specialist needs, especially regarding maternal care, where you can still have a physical presence, but get the care that you need and bring that to you as opposed to the transportation and security that you might experience. Finally, in Illinois, an integrated health system and 4 federally qualified health centers developed a digital wraparound service to supplement prenatal visits. This was utilized in tandem with in-person appointments, but it provided support and information, education, and being able to contact your providers or nurses at any point. They noticed with this improvements to infant and maternal lengths of stay in the hospital, increase to mean birth weights. It also lowered the odds of preterm birth and lowered the lowered odds of low birth weight. Finally, another opportunity is providing more education and resources to OB/GYN providers and other healthcare staff. In South Dakota, they started an extension for the community health outcomes, an ECHO program, providing professional development and maternal care education targeting low volume birthing facilities, as well as rural and underserved communities. Education and resources were provided for maternal and prenatal care providers, but they also gave education to certified nurse midwives, registered nurses, social workers, and medical students. Surveys after these sessions indicated positive feedback, increasing knowledge, and increasing clinical application of the knowledge that they received. And this is a great way to provide wraparound services to patients in maternal care settings, especially in rural areas, so they know that they can get the care that they need and that everybody on their care team is on board. And I'll stand for any questions.
Thank you. Any questions? Yes, Senator Scott.
the federally qualified health centers. I know my community in Natrona County has got one. I don't know whether it provides OB care and deliveries or not, whether it covers that. The federally qualified centers do have an advantage in that they solve the tort problem very nicely with the Federal Tort Claims Act. One of the more effective ways of doing it. What kind of coverage do we have from those centers here in Wyoming, and to what extent do they provide obstetric care?
Madam Chair, Senator Scott, that hasn't been quantified yet. That would actually be the next step of my final project for my master's, but I would yield to Jen Davis if she has some more information on that.
Chairman, Senator Scott, we have 8 entities in Wyoming that have federally qualified health centers here with 17 site locations. In Casper, we do have the Educational Health Centers of Wyoming, or the UW Family Practice, which does OB care. The residents actually have an OB track through our residency program in Casper, and the residency track in Cheyenne just started in July for OB as well. So those 2 centers are where we have labor and delivery services. So some of our other FQHCs refer over into the UW Family Practice facilities for the labor and delivery.
Representative Ottman.
Thank you, Madam Co-Chair. Hi. Do we have currently the mobile units in Wyoming, or is that something that, could be integrated into that? And if we do, how, or if we don't, how's that going to work? Are they going to come out of the regional hospitals? I mean, a baby doesn't really say what time they're going to come. So, I mean, how do you project having that kind of coverage with a mobile unit? Just ideas.
Madam Chair, Representative Ottman, a lot of these studies are specifically focused on checking boxes for the milestones, doing the tests, and following along. I don't know exactly how it would all play out, to be honest with you, and how Wyoming would be able to apply it. Just that there are other states who are attempting to do it as well. And I'll yield to Jen Davis to continue on that.
Chairman and Representative Ottman, we do have some of our FQHCs have mobile units. The mobile units go out into the community. A lot of mobile units are used for prevention, general care out in the community. So you probably could use a mobile unit for prenatal care, making sure that women are getting those prenatal visits with a mobile unit, doing postpartum care. That is, I believe, how most of them are being used across the nation. So I think there is opportunity. Some of our clinics have some mobile units, some of them do not. So again, I think it is an opportunity for us to look at a little bit more in depth, looking at telehealth services. As you all know, that can be a little bit of a challenge on a mobile unit in Wyoming if we're going into real rural areas, making sure that we have adequate service on a mobile unit so that you can have that connection to a provider should you need it. So I think there's lots of opportunities. There's also lots of opportunities through EMS and looking at how they can use telemedicine on the back of an ambulance for kind of a triage with an OB. If somebody is laboring, maybe it's a high risk and they're having to be transported. So I think there's lots of options for us to further investigate around the mobile units and the telehealth options.
Any further questions? Representative Yen.
Andrew Corbine, thanks for being here. Appreciate you, and thanks for the presentation. If you could give us one recommendation of something that you think that we should do legislatively, what do you think it would be?
Madam Chairman, Representative Yin, I do see that mobile health as an option for patients can especially bridge those gaps in areas where people lack transportation, lack access. I would say a lot of the research that I've been doing and building upon, the discussion does go around providing grants and providing funding, especially to integrated health systems such as we have for like the UW Family Medicine, to ensure that when they have students, when they have residents, they have this opportunity to go and train, and that might be a potential option for Wyoming. It gives the residents the opportunity to get that hands-on experience and become proficient, and it also serves those communities that otherwise may not have any other options.
Senator Steinmetz.
Thank you, Madam Chairman. I'd just like to visit, thank you for your presentation. You did a nice job, by the way. I'd like to visit the mobile unit idea because we just are struggling with that in Goshen County. We used to have a veterans mobile unit and they have since pulled it out because of the costs associated with it. When the equipment is running down our Wyoming roadways, it's very sensitive to that, to the bumping and clunking and all of the things that happen on our roads. But they also have indicated that refurbishing it or restoring it or purchasing a new one would not be cost effective whatsoever. And so they are abandoning the mobile unit idea. With the Veterans Administration, we've tried very diligently to address that and try to find some solutions, and they're not moving on that situation. So what is the cost associated with some of your ideas? Because we, as policymakers, would need to have those numbers to look at. And just having dealt with this situation recently, it's fresh on my mind. Thank you.
Madam Chair, Senator Steinmetz, you do bring up an important part of this, which is the cost. Startup costs throughout several of these options that I provided do have extensive startup costs, especially refurbishing, putting together the unit to be able to be capable of providing the care that's needed. I don't know necessarily specific costs of what it would look like for Wyoming and how it would be applied to the different communities. But what I would say is that reading through this, while a lot of those projects bring up the cost, they also talk about how important it is to deliver these services to underserved communities, rural communities who might not have any other options. And so the cost, of course, is an important part, but the cost is well spent for our maternal care patients and the children of Wyoming.
Follow up.
Thank you for that, and I don't think anyone disagrees with that. Do you have any possible funding sources that you've identified that might pay for these types of services?
Madam Chair, Senator Steinmetz, not necessarily. A lot of the programs that I provided were specifically through grants or programs started up by integrated hospital systems. So a lot of it is more a private effort from what I've seen from these programs that I have provided. But if you'd like, I can take a look into ones that may have started publicly, what the funding might look like, and I can get that back to you.
Yep, Representative Clausen.
Thank you, Madam Chair, and thank you both for being here. So something we've worked on, this maternal health issue for years. I know Jen was on the governor's task force. You know, a good friend of mine is a senator in South Dakota, and she talked to me about the mobile unit. But the difficulties that Senator Steinmetz just talked about with the costs. One of my thoughts was just having a mobile team that would go to the county health departments. That'd be scheduled a couple days a month. You know, we could have different teams throughout the state, but using the facilities that are already in place instead of having these mobile vans that are hard to upkeep and expensive. Your guys' thoughts, either one of you, on having expert teams going to these different county health departments that are already in place?
Chairman, Representative Closton, I think you bring up a good point, as well as Senator Steinmetz. The cost of mobile units is pricey. I like that idea. I think that those ideas have been tossed around some too, about thinking of how do we get services to patients. And so using that mobile concept, but moving the team as compared to using a unit, I think could be a cost option. I think we see that in some of our health systems where they bring in specialists into some of our rural communities. Maybe a cardiologist comes into the community one day a month or something. So I think we see some of those models. And I think it's definitely something for us to think about and look at. As you all very much know, this isn't going to be one solution to this problem. I think we're going to have to look at multiple options. And the more we look at things like that, I think the better opportunities we have of utilizing things that already exist. So I think that's definitely something to investigate for sure.
Any further questions?
Well, I just want to say thank you very much. I very much appreciated your presentation. It hit all my nerdy points as like a former labor and delivery nurse, a nurse who loves research. Well done, and thank you for being here. So appreciate it.
Thank you, Chairman and Committee, for allowing him to do this today. Really appreciate it.
Yeah, thank you. Okay. We do not have breaks built into things, and I know no committee ever like breaks. We're gonna break for like literally 5 minutes, a stretching, get up, do some jumping jacks, blood flow to the brain, get a cup of coffee. 5 minutes. Say hi to the person sitting next to you. Lucas Williams is like. Okay. Next, we're going to get some information from our research division in the Legislative Service Office.
Good morning, Madam Chairman, members of the committee. Clayton Caldwell, research analyst with the Legislative Service Office. I have provided for this committee a short report that summarizes a few different strategies for improving maternal health care access and maternal health care outcomes that are used in several different states. I'll briefly summarize the contents of this short report and then I can stand for any questions. So there are many different strategies that are being used by states to address maternal health care, but the three that I focus on for this short report is one, including doulas under the state Medicaid plan. Two is allowing more kinds of telehealth to be covered by a state's Medicaid plan. And then three is integrating midwives into the state healthcare system. For the first one, doulas are covered under Medicaid in at least 12 states, with that list growing, but not in Wyoming. And then for telehealth, Wyoming covers video-only telehealth services under Medicaid, while other states include more kinds of telehealth that are covered under their Medicaid programs. And then regarding midwives, Wyoming grants certified nurse midwives a full and independent scope of practice and also reimburses both certified nurse midwives and non-nurse midwives at 100% of the Medicaid reimbursement rate. And then information regarding the availability of maternal health care in Wyoming and across the United States is on page 3. That's a brief summary of the contents of the report. I can stand for any questions.
Appreciate the briefness. Any questions? Senator Steinmetz.
Thank you, Madam Chairman. Just a question, and it's been a long time since we met last, so if we talked about this before, I apologize, but is Medicaid the only problem, regarding these healthcare deserts, or is it more broader in scope than that? Do you know what I mean? Why are we just focused on that? Could you remind me of that? Thank you.
Madam Chairman, Senator Steinmetz, the causes of maternal health care deserts are varied and complex. And so I briefly summarize some of those causes. A major component is, of course, rurality. Wyoming has a lot of rural counties, and because of that, that can reduce overall access to maternal health care, not only by increasing the prevalence of maternity care deserts, but also increasing travel time to the maternal care centers that are actually available. And that information starts on page 3 and then it ends on page 4. Regarding the use of Medicaid, I discussed these particular strategies because, one, I haven't heard these strategies be discussed in previous meetings. And also these are strategies that are used in a lot of states. Improving access to doulas under Medicaid is used in currently 12, but that list is increasing. 11 other states are also working on this as well. And then regarding telehealth, Wyoming is the only state that only reimburses video-only telehealth services under Medicaid, whereas every other state in the country reimburses at least one other kind of Medicaid service. And that information is summarized on page 12. I hope that answers your question.
Any other questions? Senator Scott.
Madam Chairman, 2 questions. First is just what is a doula, and do we have any prospect of having any in Wyoming? The second one from the prior presentations, the thing that came home to me, Madam Chairman, was that the real problem was low volume. And with a high fixed cost, low volume is very important. And do any of these other things really address that low volume problem, or is that strictly we need to reimburse more?
Madam Chairman, Senator Scott, to address your first question regarding doulas, and that would actually be starting on page 8 of the report. But to briefly answer that question, doulas are trained professionals that can support pregnant and expecting women across their pregnancy. They're not medical professionals, but they can work alongside medical professionals to be part of a pregnant woman's maternal health care team. And the states that reimburse for doula services do provide those doula services at different points of pregnancy. Additionally, there is evidence to suggest that access to a doula can improve healthcare outcomes and also reduce costs. Further, there's also a lot of evidence that the desire to have access to a doula is much lower than the ability to access a doula. And that is due to a lot of reasons, but one of them is that doulas are generally not covered by insurance. And again, currently only 12 states allow doulas to be reimbursed under Medicaid. But then regarding your second question regarding addressing the rurality of maternal health care services, some of these do address all of that in some way. Again, maternal health care access is very complicated, but telehealth, for example, there is evidence that this can be a useful way of addressing those healthcare shortages, in part because you're reducing the travel time of people who receive maternal health care services. If someone is able to simply call in, that makes it much easier for pregnant people to access those maternal health care services. It's particularly useful for low-risk pregnancies because a telehealth service or a telehealth appointment might be just as useful or almost as useful as an in-person appointment. So that would be one. Access to doulas can also help as well, just by virtue of increasing the kinds of healthcare providers that are available in a particular area. And then a similar argument could be made for the availability of midwives.
Madam Chairman? Yes. Senator Crum has his hand raised.
Okay, we'll go to Senator Crum and then Senator Steinmetz.
Thank you, Madam Chairman. My question is on telehealth. I see some great benefit from that, but how are tests done? Like a mother, how would like an ultrasound be done, or chest blood pressure, those type of things in a telehealth appointment, just for educational purposes for myself? Thank you.
Madam Chairman, Senator Crum, there are a few different kinds of telehealth appointments that you can have. The main ones would be, there's video, which is covered by Wyoming Medicaid, but then there's also store and forward, where appointments may be requested or certain services might be requested digitally, and then that information can be stored and then sent digitally. So for example, if a medical professional requests blood work, you might be able to get that blood work in your own community without having to actually travel. So in that kind of circumstance, specific tests or specific ultrasounds could be made at somewhere, could be requested to be done somewhere that is actually convenient, whereas an in-person appointment might be a bit further away from where you live.
Thank you.
Senator Steinmetz?
Thank you, Madam Chairman. I want to go back to the doulas. So I just kind of did a little looking up, and it says that the Affordable Care Act currently covers doulas. So if people were wanting that coverage in there under the Affordable Care Act, that should be available to them. And it also says that it in states where Medicaid expansion plans went into effect, they cover the doula care. So and I still don't sometimes understand with the parameters of the Affordable Care Act, I mean, Medicaid really, it's in some ways competing with that. But so can you answer that as, I mean, why are people not using doulas? They are, many people are covered under the Affordable Care Act in Wyoming. And so what is the demand, I would ask?
Madam Chairman, Senator Steinmetz, I don't have any information regarding doula coverage under the Affordable Care Act. All I can say is that doulas are often not covered under private insurance options. And one of the major reasons for that is usually doulas are operating independently. And so navigating a private healthcare system can be very difficult for a lot of doulas. So for that reason, a lot of doulas are not covered under insurance. And very often those who are receiving doula services are simply paying out of pocket. However, I would just like to point to Appendix A, which does provide the benefits that are covered under states that do cover those doula services under Medicaid. So the kinds of services and the kinds of appointments that might be permitted can vary greatly. For example, in California under Medicaid, pregnant women are eligible to receive an initial 90-minute appointment and then an additional 8 prenatal appointments, but more appointments can be permitted if they're approved by a healthcare provider. So just the kinds of appointments that could be covered can vary greatly.
Madam Chairman, my question is why are the doulas relevant at all? If you look on page 8 of your report, now that I've located the right report, doulas are not medical professionals and do not provide medical services. And the problem we're trying to deal with is deserts in Wyoming where there are flat, not the medical professionals that we need. So it does seem to me that we need to deal with why are those medical professionals not there? And this is just a irrelevancy. And we need to focus on what's wrong with the economics and what's wrong with the legal climate that is giving us trouble recruiting adequate obstetrical services. What am I missing here?
Madam Chairman, Senator Scott, the kinds of services that can be used to support a pregnant woman throughout the pregnancy, it's not just the pregnancy itself, it's also the first year after the pregnancy. This is called the perinatal period. And so there's a wide variety of kinds of supports that can be provided to women to support them in that pregnancy. And even if a healthcare provider is available, providing support during that either before they're pregnant or after that pregnancy in that first year, that can improve a wide variety of healthcare outcomes. So in the states that are improving access to doulas, one purpose of that is to improve overall mental and healthcare outcomes for people giving birth within the state. Again, I would like to reiterate that there is a discrepancy between the desire for services. Roughly 9% of surveyed women are able to receive access to a doula, versus 57% are actually interested in receiving a doula. So that would really be the purpose of iterating, or the purpose of supporting doulas under a Medicaid system.
Representative Clouston.
Thank you, Madam Chair. Thank you for being here. I'm going to give you a little context and then I'll ask the question. So all summer I've worked with a group nationally on this issue. There's about to be released a peer-reviewed study on addressing this issue. The number one solution, so when we look at increasing the reimbursements, what we pay for deliveries, we're going to reimburse where those are already happening. But the problem is, how do we get providers to areas that are not being served? This peer review study is coming out. The best program that they found was in North Carolina. So North Carolina provides malpractice insurance liability reimbursements, $6,500 for an OB, $3,000 for a midwife, if they go do deliveries in underserved areas. It's been very successful. It's been, so everything that these studies looked at, this was the best way to get providers to areas that weren't being served. North Carolina has 11 million people. The program cost the state $800,000. So my question to you is, do you know, or can you get us information, how many OB docs in Wyoming are performing deliveries and how many midwives? What I'm trying to come up with is, what would a cost to Wyoming look like if we were to implement the same program?
Madam Chairman, Representative Clouston, I don't have that specific information. I may have to defer to the Department of Health. All I can really say is that, and I have a presentation later regarding malpractice insurance for OBGYNs. But all I can really say for Wyoming law is simply that Wyoming seems to be, I'd say, roughly middle of the pack regarding what our specific laws are. Under Wyoming statute, there's a $500,000 requirement or annual coverage minimum for OBGYN malpractice insurance with an annual limit of $1 million. Wyoming also statutorily does have a I guess you could call a malpractice insurance fund that is established by statute, but Wyoming doesn't fund it doesn't fund that fund simply because malpractice insurance is considered a private market and there are private options available. I hope that answers your question.
Any further questions? Oh, yes, sorry, Representative McCann.
Thank you, Madam Chair. This might be a question for your later presentation. As a provider, you have to look at the legal stuff. All right. In your research, did they address that? A lot of the problem is the malpractice insurance companies will not go to court. It's much cheaper for them to just settle. Doc might not have done anything wrong, but he doesn't get his day in court. And then he gets a little black mark in the big black book. And you get enough of those, they're going to yank your license. Now, generally speaking, you get enough of them, it's probably you're doing it. But, you know, you have to take that into consideration in the fact that, you know, as a provider, I don't really know if as an orthopod, I got to put my hands on them. You know, and you know, that's where you're going to probably lose some providers in the fact that they can't put hands on. And then the legal ramifications of that. Well, why didn't you do that, doctor? And did you come across any of that? Thank you.
Madam Chairman, Representative McCann, I would just refer to the report that we'll be seeing later, the memo on OBGYN liability insurance. But just to briefly summarize that information, OBGYNs that's considered a pretty high risk practice just because the risk of serious injury and lifelong injury is relatively high compared to other medical specializations. And so for that reason, liability insurance for OBGYNs is just about the highest. And there is a little bit of information in that memo regarding that. I didn't look into specific strategies regarding how to address that. And part of the reason is because the actual data on what that looks like is actually pretty debatable. A lot of the information regarding how that might be affecting OBGYN practice does rely on a lot of anecdotal evidence. So it's just, there is a lot of discussion on what exactly those numbers might look like. So it's just not clear at this time. But in any case, you are right, Representative McCann. It is a contributing factor. It is important to consider.
Thank you, Madam Chair. Mr. Caldwell, I've been on this committee for a little bit, and it just seems like this whole thing on maternal deserts has just kind of come up within the last couple of years, at least in my hearing. What has brought this about? Number one, this whole desire to deal with pregnant women in rural areas that we know pretty much the whole state is rural. Why Medicaid is a factor in paying for any medical costs? And why not have the mother, father pay for their own paternal costs? If you can answer a few of those for me, I'd love to hear it.
Certainly. Madam Chairman, Senator Hutchings, just to answer the first question regarding kind of the causes of maternal health care. The causes of maternal health care deserts are actually pretty complicated, but I did briefly touch on just a few of them. Across the United States, and by the way, the United States has the highest levels of maternal health care deserts of high-income nations. So that would be one reason why it's a modern discussion. Across the United States, 35.1% of counties are considered maternity care deserts. As for the causes, some of those are systemic issues, particularly if other kinds of health care are missing from a community, that can have runoff effects that negatively affect maternal health care. So for example, diabetes or hypertension can result in lower maternal health care outcomes. And that's an important factor as well. Even if there's a little bit of maternal health care, if the overall quality of health care is lower, then that will reduce the health care outcomes as well. But then speaking to Wyoming specifically, Wyoming is roughly middle of the pack in terms of overall availability. Wyoming is ranked 21st among US states in maternal health care provider availability. But as Senator Scott iterated earlier, a major component of that is just how rural the healthcare is and how difficult it can be to provide healthcare to those rural areas. And again, even if a county has a healthcare provider, if the travel time to that healthcare is large, then that can also negatively affect the quality of their healthcare. So because there's a wide gamut of ways that you can support people who need maternal health care services. Then speaking on your question regarding Medicaid, I believe it's roughly 35% of, no, I think that's Wyoming. Across the United States, 40% of all births are covered by Medicaid. And then in Wyoming, it's roughly 35% of births are covered by Medicaid. So the reason a lot of states are doing this, are trying to use Medicaid to cover more kinds of services, is because Medicaid is commonly used. So these would be low-income families that would be using Medicaid to support their pregnancy. And I have a little bit of information on that if you're interested. That would be at the bottom of page 5 and the top of page 6.
Any further questions? Okay, if you want to go ahead and just give us a little bit of, go into the memo on the OBGYN liability insurance and Wyoming statutes right now, that would be great.
Yes, Madam Chairman. Just to briefly summarize that memo, I alluded to it earlier, but liability insurance is used by healthcare providers in cases where they might be facing claims of negligence or malpractice in court. Generally, the way it works is there is a minimum annual coverage amount for healthcare providers, and then there is a maximum coverage limit. And as I mentioned earlier, under Wyoming law, the minimum annual requirement is $50,000 per year. So any coverage policy must cover a minimum of $50,000 per year. But then the annual limit is $1 million per year. And that is outlined in Wyoming statute. Now, speaking on how that affects providers, OBGYNs typically pay the most. And again, that would be because OBGYN practice is particularly high. One of the most common causes of malpractice claims for OBGYNs would be either permanent or neurological injury during the birthing process. So the kinds of injuries that they are prone to are significant. That's a brief summary of the memo. I can answer any other questions.
Any questions on the memo? Okay. We'll go Senator Scott and then Representative Ottman.
Madam Chairman, you talk about a 1 million annual limit. Madam Chairman, my understanding is there wasn't a limit on the liability coverage and then that the doctors will insist on a much higher limit than that. Where's this 1 million come from?
If I could just grab the actual memo, I can explain this, where the statute is.
Thanks. My apologies. I kind of threw this one out at you.
Yes, certainly. Yeah, so if you would look at the last page of the memo, I provide the citations for that specific statute. That would be Title 26, Chapter 33, Section 102. That's where the requirements for physicians who have liability insurance in Wyoming, those are the statutory requirements for liability insurance policies. And they specifically indicate a minimum coverage of $50,000 per malpractice claim and have a coverage limit of $1 million annually.
Chairman, that's the insurance statutes, all right. I have a feeling that that particular statute is flatly irrelevant to the question at hand. I think malpractice policies, and some of the medical people here can tell me better, but I think they're typically much higher than that, are they not?
That is a great question that hopefully somebody has the answer to. So we'll hopefully get an answer to that by the end of the day.
Madam Chairman.
Yeah, Senator Steinmetz.
Thank you, Madam Chairman. I don't know with regards to physicians, but I can tell you for other professions, it's considerably higher than that. So I would be surprised if it was that low.
This is in the medical malpractice alternative in the statute that's simply not been used. And I don't think it's ever been used. It was enacted and proved to be irrelevant, and I don't think it has any effect on the real world.
That is, I would guess that you're probably right because I haven't heard of this, but being enacted, but we'll do our best to come up with some answers. So, Representative Ottman.
Thank you, Madam Co-Chair. Good morning, Mr. Caldwell. Thank you for your paper and all the information that you provide. What I'm wondering is, it seems as though there's been an increase in discussion of postpartum, and whether that be mid-term of the pregnancy or following up. Does that affect, or is there any discussion with any of these topics with the DUVA or the insurance or Medicaid reimbursement or the insurance covering? Because there shouldn't, well, is there any discussion on that?
Madam Chairman, Representative Ottman, yes, and that is one of the purposes of supporting access to doulas. If you look at the coverage policies for the states that cover doulas under Medicaid, some of the covered appointments will be either before or during the pregnancy, and some of them will specifically be for after the pregnancy. So what you do see is efforts to not just support the 9 months of pregnancy, but also that first year after. And a common reason for that, as you alluded to, is that there can be a lot of health or mental challenges that occur within that first year of that first year following pregnancy.
Any further questions? Representative Clouston.
Thank you, Madam Chair. Thank you, and I don't know if you'll have this information either, but looking up average malpractice liability insurance in Wyoming costs our physicians about $55,000 a year. North Dakota and South Dakota are both below $20,000 per year. Do you know why our costs in Wyoming are so much higher?
Madam Chairman, Representative Clouston, I can't specifically say why they would be higher in Wyoming. What I can say is that the cost of liability insurance can vary widely by geographic setting. And I do have just a little bit of information regarding the specific costs. A survey in 2021 regarding OBGYN malpractice costs found that 27% of OBGYNs paid an annual premium under $20,000, and a third of OBGYNs paid an annual premium of at least $30,000. But they can be significantly higher. I believe in Florida, some OBGYN practices pay over 100. So they can vary significantly by state and even by county.
Senator Scott.
Madam Chairman, let me try to answer that last question. We have a long history in Wyoming in the medical malpractice area of being a very expensive state. And we, over the years, have seen the carriers change quite a bit. At one time, we had two carriers, one of which was the Ohio. Well, we had insurance through the carrier down in New Mexico come up here, and their regulators in New Mexico forced them to leave Wyoming because the losses were so great. We then got a carrier in from Ohio, and we essentially bankrupted that outfit. They withdrew from Wyoming, and then they went broke. So we have had, because of high costs in Wyoming, which is a mixture of the lack of any kind of limitations and a mixture and the overall legal climate here, have run those costs up, largely independent of any real harm being done. And the key study there was actually not done in Wyoming, but as a follow-up to the Harvard medical practice study that was the source of the high-end medical error estimate that the National Institutes of Medicine were using. They looked at the malpractice cases they had and found that in 40% of the cases that they found, and it's typical of Wyoming too, no cases that went to court. They just don't. They're too expensive. They found that in 40% of cases where there was a settlement, there was no medical error. They also found that in the cases where there was a settlement that didn't involve any finance, essentially the plaintiffs gave up. In 8%, and I think it was 30% of those cases, there was in fact a medical error. The system just simply doesn't work, and it's expensive. And that is a problem across the United States as a whole, and we've got it worse.
Any further questions? All right, thank you. All right, we are going to go ahead and start with our bill drafts. We'll start with 26 LSO 0134, Medicaid rate increase and obstetric services. And I believe we've got a presentation on those bills from LSO.
Good morning, Madam Chairman, members of the committee. Madam Chairman, would you like me to go through all the bills at once or take them one by one and take questions? It's totally your prerogative.
Let's do. We'll do one at a time, I think.
Okay, that works.
Yeah.
So first, we have this first bill draft, which is entitled 26 LSO 134 Medicaid Rate Increase Obstetric Services. It was requested at the last labor meeting in June. So if you begin on page 2, the bill draft indicates that obstetric and gynecology services will be reimbursed at 105% of the current Medicare rate for those services. And in order to qualify for that rate increase, OBGYN providers must offer to the patient or refer the patient to prenatal health programs developed by the Department of Health. And then beginning in subsection B on the bottom of page 2, critical access hospitals that offer labor and delivery services authorized under Medicaid will be reimbursed for inpatient services at 100% of the actual cost for all services offered. And then section 2 on page 3 requires the Department of Health to report to the Appropriations and Labor Committees regarding the additional costs incurred by the increased reimbursement rate under this act. And then in section 3, beginning on page 3, we have an appropriation of $200,000 from the general fund and $200,000 from federal funds for OBGYN services. And then we also have an appropriation of $8.3 million from the general fund and $8.3 million from federal funds for critical access hospital services. In the staff comment on page 5, I indicate that these appropriations are to be included in the Department of Health standard budget for the immediately succeeding fiscal biennium. And this is a policy choice for the committee to decide whether or not they want that language left in. And then in section 4 on page 5, we have an effective date, and I would stand for any questions.
Any questions on this bill from the committee?
Madam Chairman.
Yes.
When we did this before, and I think we did it with budget amendments rather than statute, and we did it after the tort reform effort failed in I think it was 2006, if my memory serves me right on the date. What we did was we ran the OB compensation on Medicaid right up against the federal limit as to how much we could reimburse and still get the cost share from the feds. This doesn't do that. This does a percentage. Why did you do it that way? And how close are we to the federal limit with the way it's written?
Madam Chairman, Senator Scott, let me pull up a little bit of information real quick. Hang on. So, Senator Scott, right now, the reimbursement rate for OBGYN providers is at 100% of the Medicare rate. So this would be just a 5% increase. For the critical access hospitals, I'm not entirely sure what the percentage is right now. I don't have that information, but I would defer to the Department of Health for that. They probably do have that information. And the reason I did it this way, I believe that the ask at the last labor meeting was for just a non-codified bill draft to increase these rates. And so I took a bill, I believe it was from 5 or 6 years ago, and basically resurrected it with these new numbers. But it would totally be a policy choice how you'd like to do this. As far as like doing the increases, I could do it in a different way if the committee so wants me to.
Madam Chairman, when we hear from the health department and the Medicaid people, I'll have the same questions.
Great. Any further questions from the committee for LSO? Representative Wasserberger and then Senator Hunt-Jenkins.
Thank you, Madam Chair. Thank you for giving the presentation on the bill. One of the questions I have is on, I believe it's page, I'll get back to you on the number of the page, but it was about the amount of funds that would come from the state and the amount that comes from the federal funds. It came up to 50-50, 8.3 million, 8.3 million. The big beautiful bill that Trump proposed passed in July, and that's going to change the federal funding from 70 to where the state has to pay about 75 and the federal will pay 25. Has that been taken into consideration with any of these bills?
Madam Chairman, Representative Wasserberger, we haven't taken that into account with these bills. I would defer to the Department of Health whether or not we need to. But these bills were written in June, July, so that wasn't taken into account here, but I would defer to Mr. Fuchs on whether or not we need to do that.
Senator Hutchings.
Thank you, Madam Chair. This is question, I don't know if it's proper to address the person that proposed the bill in the first place. Were they expecting the $8,500,000 match at that time?
Madam Chairwoman, Senator Hutchings, we didn't know at the time when the bill was requested how much that appropriation would actually be.
Representative Ottman.
Thank you, Madam Co-Chair. Just a question, and maybe this would also be for the Department of Health. But when we look at the critical access hospitals and things, what I believe is that that would be, there's certain doctors that have permissions to use or licensed or whatever under a hospital. So with the critical access hospitals and others, if a patient isn't currently under a doctor's care for pregnancy, for maternity, and something happens to them, would that then be covered under this, or would that just be an emergency room thing, or do they have to have a doctor that they're seeing?
Madam Chairwoman, Representative Ottman, I think what you're asking is whether or not this rate increase would count for any doctor in the hospital. Is that what you're asking?
Well, any patient.
Any patient. So any patient that is covered by Medicaid, it would cover any patient at a critical access hospital, whether or not they're receiving OBGYN services. So this raises the rate for any service at a critical access hospital.
Any other further questions for LSO? Okay. We're going to go ahead so that we can keep things straight. We're going to do one bill at a time. So how many people in the room are here to testify on this bill? Okay, so if you guys can go ahead and come forward, and we obviously want to hear from you and the important things that you have to say, but also realizing we have several bills. We love short, succinct, to the point, if that's possible in the world of healthcare.
Madam Chairman, I'm Jesse Springer. I'm the interim state Medicaid agent. I'd like to just answer a few of the questions that came up during the previous section. So currently we're covering 72% of cost at critical access hospitals that deliver babies. So we've gone through a process of actually creating a special hospital group. First, we created a critical access hospital group. Seeing the issues with maternity care continue to develop, we've actually created another group within our reimbursement structure that's specific to critical access hospitals that deliver babies, so that we can then deliver a specific price if you wanted to increase the cost coverage. So that's kind of our mechanics, but we've done that now. We have a way to pay critical access hospitals that deliver have OB services. So that is the cost, and that allowed us to produce the cost estimate for this bill, specific to cost critical access hospitals. To the question on percentage of Medicare, that's so Medicare is generally on the physician side, on the professional services side is a barometer we use for cost. Medicare does a number of cost studies. We're currently paying 100% of Medicare for delivery services only. So that's not a full range of all OB services, but we have delivery, prenatal, and postpartum care. But that doesn't mean that we're paying 100% of Medicare for every service that an OB does, just limited to these maternity care. And that's why the price tag of that particular going to 105% is relatively low. If you wanted to go to a higher percentage as a committee, you just would need to, if you want to go to 110%, double the number. There's no limit specifically how high we could go. We used to be at 150%, for instance, of Medicare. We are limited as a state in our upper payment limit calculations for all physician services, but because maternity is only a portion of that for Medicaid, we likely could go to a very high number if desired. But generally, we're paying most services at 90% of Medicare. And so maternity and a few other services are an exception. They're being paid 100% of Medicare just due to Medicaid being a high percentage of the overall care in that area, and also just trying to maintain those services.
When you said we were at 150% of the federal Medicare, when did we back off from that? Because that was where we went after the tort reform failed, was it not?
Madam Chairman, Senator Scott, if you go back 12, 13, 15 years ago, there were much higher rates in place. And without additional funding being added, those rates have essentially slipped over time in terms of what the barometer is, but there's also been multiple rounds of budget cuts since that time. So our cost coverage has slipped from that 150% plus level to the level it is today.
So if we went back to 150%, what would that cost us? What kind of appropriation would we have to put in the bill?
Madam Chairman, Chairman Scott, it would be, if you wanted to go to 150%, it would be 10 times as much as this. So it would be $2 million general fund and $2 million federal funds. And that would only cover prenatal, delivery, and postpartum services. We currently have a delivery bundle, so if women are receiving prenatal care and delivery from the same physician or midwife, certified nurse midwife, family practice physician, any of those nurse practitioner, they get the bundle. And then we have carved out postpartum care because we were seeing it being underdelivered in the bundle. So we have carved it out of the bundle. It's no longer part of the bundle, and we have removed all limits on postpartum care because we were just seeing underuse of postpartum care, and it was leading to a lot of high cost events, maternal mortality. So that hasn't had a major cost impact. We haven't seen a ton of uptake, but what we're trying to do is get to above 1. A lot of women were not getting at least 1 postpartum visit, and we want to get to 3 would be our ideal. That's the guidance that we have from a number of medical associations, and there's certain timelines that would be ideal that those would be occurring. So as part of, we've been actually working on this issue for a long time internally, and we've been trying to make as many changes as we can within our existing funding and our existing authorities to try to address this issue the best we can.
Yes, Madam Chairman. So this going to 150% would not cover the postpartum care? What would we need to do to cover that care And the second question is, you're talking about critical access hospitals here too, but I know we're having trouble in Casper with non-critical access hospitals and reimbursement there, and we would need to cover that too, would we not?
Madam Chairman, Senator Scott, the effort we've been trying to do is maintain the base level of maternity services and ensure there is delivery at a wider array of hospitals, because you know the number of hospitals that have been eliminating this service, and that has primarily been at critical access hospitals. The price tag, if you go outside of critical access hospitals and go into the larger hospitals, including out-of-state hospitals, would be multiple orders of magnitude larger than this. The $8.3 million is, it's a very big number, but it would be a much bigger number, $50 to $75 million, if we were going into the PPS hospitals and also getting into the out-of-state births that are occurring. If you're going to target your funds, the critical access hospitals that have delivery, this was a way to, ensure that those continue in more communities of Wyoming. We could absolutely provide that sort of idea for cost coverage at for all hospitals within Wyoming that have maternity services. My warning would just be that number will be much bigger. It'll be a much, it'll be a very costly change. So this was an incremental, I think, change to try to shore up some hospitals and maternity services overall on the physician and professional services side. Madam Chairman, if I may, could I just make a few comments about the bill itself? Would that be appropriate?
Yeah, but I think Representative Ottman has
Oh, I'm sorry.
question,
Okay.
and then I would love.
Yeah, a couple more questions, and then comments on the bill would be great.
Thank you, Madam Co-Chairman. Yes, I have a couple questions. One, we see that the money that we are appropriate or looking at in this bill goes directly to the Department of Health. And so are they then in charge of dispersing it to the hospitals and the physicians and all of that? And what do they base that on? Also, I would like to know what costs really are included to a hospital for maternity. I mean, what are the charges? And the last question is, do patients understand what their coverage is or what they need to do to obtain coverage other than you should come back for a visit? Is that made explicitly clear to people?
Madam Chairman, Representative Ottman, last question first. So we have a maternal, in the last 2 years, we've made we used to have one client booklet. It was quite long, and it covered all the different scenarios for all clients. We've, since that time, actually developed a child health guide that describes what Medicaid covers. We have a pregnant women guide that's specific to maternity care and situations that pregnant women would be facing. And then we have an adult medical guide. So that, each one has their own booklet now. So we try to make that a lot clearer about what's covered. Almost all these services have no cost sharing under Medicaid allowed for maternity care. So maternity care, there's no cost sharing. There's very few limits in terms of how many prenatal or postpartum visits women can access. And we try to make that as clear as possible. And then we also have a service that, on the first visit, we have physicians bill us. It's $100. And it's basically a referral for care. And if there's anything noted in terms of health conditions or other issues, we refer them to our health management program and begin services. The way we pay, so if all the funding under this bill would be paid to providers using, they bill us using medical claims. So the physicians would bill us using a medical claim form. The the hospitals use a different claim form, but basically they denote, hey, we served a Medicaid client. Here are the services we provided, and we use fee schedules or a number of pricing methodologies to pay those claims. And so basically that's the documentation that we get to say, hey, this service has occurred, and here's the service that was provided. And then we use the different pricing methods to pay that claim. And so what this bill would do is increase the amount we would pay per claim to a higher level, targeting either Medicare, a percentage of Medicare, or a percentage of cost. Madam Chairman, Representative Ottman, there was one more question.
Another question? Yeah. Okay, our NEC, would this increase the availability to NICU services, or do we still not have that available in Wyoming?
Madam Chairman, Representative Ottman, this bill itself would not likely change availability of NICU. So we have two level 2 NICUs, one in Casper, one in Cheyenne, and then we have a number of enrolled NICU 3s in Utah, Colorado, and a number of other places. So those generally are wherever the child is life flighted to, or if the mother was traveling, did they give birth in another community? So we do have, in some cases, some facilities enrolled with us just for one birth, but generally we're sending to Salt Lake City and Denver for a majority of the NICU level 3s. A number of children are served in state at the level 2 NICU.
Thank you. One more. Okay, with an increase like this, is it to increase services, or is it to increase the payback of services that are already being provided?
Madam Chairman, Representative Ottman, this bill itself is not increasing what we cover. So it's not adding any providers. It's not adding any new services. It is purely a reimbursement bill to pay a better level of cost coverage for the services already being provided. What could happen due to this bill is there will be more provision locally, and so where the service is occurring could change, because if the service is more financially sustainably locally in the communities that are getting this higher reimbursement, there may be more closer to where the women live, but it wouldn't change the overall services that Medicaid is covering. Madam Chairman, any more questions? I'm sorry.
Senator Steinmetz.
Thank you, Madam Chairman. I just have a few budgetary questions. So first of all, what is your anticipated total budget for the Department of Health this coming budget session? If you know that, if not, give us the amount from the last budget that you submitted. And then how much in this section, under this category, what is your estimated budget there as of right now, if this bill doesn't pass? And then what are your expected reversions? And is this, if this becomes a part of the standard budget, is it figured just like the rest of standard budgets where we add inflation every year to deliver the amount of services provided at the same level? So is there an automatic escalator in this budget already? Thank you.
Madam Chairman, Representative Steinmetz, or sorry, Senator Steinmetz, I'm sorry. The standard budget within the Department of Health Medicaid portion for 600 series, which is our benefits, does not have an auto inflator in currently. So there is no inflation adjustment to the Department of Health Medicaid budget for benefits occurring on any service. So when we have a standard budget, if we had $100 appropriated by the legislature in one biennium, we will be appropriated for benefits $100 the next biennium. So these amounts do not escalate, and there's no inflation adjustment in statute of any form on Medicaid paid benefits that are in the 600 series. To the overall funding level of the department, I could speak to the Medicaid budget, but I'll let the director of the Department of Health speak to the overall budget.
Madam Chairman, members of the committee, Stefan Johansson, Director for the Department of Health. Senator Steinmetz, to your question, our current standard budget is approximately $2.1 billion for the biennium. And as Mr. Springer mentioned, that is for all of our programming and services, not just including Medicaid, but also behavioral health, public health, aging services, and our 5 state facilities. You had asked a question, Senator Steinmetz, about our projected reversions. That is a moving target, obviously, throughout the biennium, but it's a good question because in the previous 2 bienniums, so 21-22 and 23-24, members of this committee and certainly the Appropriations Committee remember we generated a significant amount of general fund savings for the state. In fact, in both of those bienniums, totaling near or over $100 million each biennium. That was driven by quite a few factors. Some of it was enhanced federal reimbursement that we had, but also vacancy savings and other costs that we didn't spend throughout the Department of Health budget that we locked down in an account so that we could come to the legislature and the JAC during budget cut cycles and offer one-time funding to offset budget cuts or investments that the legislature wanted to make. For example, our state hospital has an old campus there since that facility was rebuilt. A capital construction demolition account was created and funded primarily with Department of Health savings about 3 years ago. This biennium, Senator Steinmetz, we're much more on the razor's edge of what we're projecting to have in general fund reversions. That could change between now and June 30th, but we're projecting anywhere from $0 to $4 or $5 million in general funds. So there could be something there. Certainly, but what we always like to advise with the legislature, the Appropriations Committee, is to just note that those reversions would, if used and deployed, would be one-time savings and thus, in this case, one-time expenditures. And so it's kind of pick your poison. What would you, as a legislature, like to deploy those savings to versus just reverting them back to the general fund, which is our standard practice if there's no other policy orientation. And finally, Madam Chairman, if I may, Representative Wasserberger asked a question earlier about the effects of the One Big Beautiful Bill Act, H.R. 1, and its impact on Department of Health and Medicaid federal match rates. We do not anticipate any changes to our federal match rate resulting from that bill in Wyoming Medicaid. So the numbers that you see here in both sections of the appropriations, both the 200,000 and the 8.3 million, we don't anticipate that federal match rate is reducing. Maybe what you're referring to is either some other states with different program structures, Medicaid expansion states, et cetera, that are seeing or will potentially see federal fund withdrawals as a result of that bill. Wyoming's in a better position where we don't anticipate those match rates reducing for a variety of reasons, but we'll certainly notify the committee if we believe that interpretation should change. But we're relatively confident that our general 50% federal match rate across our broader Medicaid program, and then our other enhanced match rates, for example, the Children's Health Insurance Program, technology match rates are higher than 50%, in some cases 75% and even 90% federal match. We don't anticipate changes there resulting from the bill. So I think the numbers here in terms of what you might appropriate for Medicaid reimbursement will be able to be matched at that 50% level.
Follow-up?
Thank you, Madam Chairman. And could you please answer the other question as to what is the budget for this area right now, the area the bill considers?
Madam Chairman, Senator Steinmetz, I think we'd have to get back to you on that. I just don't have that for pregnant women category and specifically hospital and critical access hospital birthing or labor and delivery costs. It wouldn't necessarily be a standalone budget in the Department of Health's budget book, but we could certainly look at what those expenditures have been and in the broader units, what that budget authorization is and get back to the committee.
Madam Chairman, that's what I would like to see is that however you categorize it, a look at that main category. Thank you.
Thank you. Further questions? Okay, I believe you wanted to make a
Excuse
few
me.
comments on the bill.
Excuse me.
Oh, yep.
Just-
Nope, Senator
Just
Hutchings.
a quick one, Madam Chair, to whomever wants to answer it. We have a very low population here in Wyoming. How many pregnant women are covered each year?
Madam Chairman, Senator Hutchings, it's been declining over time. So, you know, they did, the LSO did reference the Medicaid birth report that is available on our website. There's a birth report that details all births and the number of births on Medicaid, and that's on our Department of Health website. I believe there's 2,000 births on Medicaid in a given year, but you know that has ranged from 3,000 or so 10 years ago to a lower number today. We are one of the lowest states for number of women delivering on, you know, with their insurance covering being Medicaid. So other states, you know, I think some of the highest states like a West Virginia, maybe like a New Mexico, they're at 50% or higher of births are on Medicaid. In Wyoming, where, you know, the most recent birth report, I think, was at 32%. I think they also referenced the report that was available at the time, which was the year before, which was 34 or 35%. But it's continued to decline over time. So the number of births we're paying for is just declining. So, you know, and generally those births are being paid for by other sources, private insurance, employer-based insurance, marketplace plans. So the other 68% is paid for by other payers. I don't believe most of that is turning into uncompensated care, because we do have options for emergency services and other things like that.
Senator Steinmetz?
I know we're trying to hurry this along, so thank you, Madam Chairman, but I think this is an important question. So this is not just pregnancy care, it's OBGYN care. Is abortion part of that? And does this cover abortions? Does it fund for that? Thank you.
Madam Chairman, Senator Simons, so this budget does not pay for abortion at all. We, you know, in a given year, I think we've reported this. There are some federal stipulations, but in a given year, we pay for 0 abortions from the Department of Health Medicaid budget. In a rare year, there may be one that meets the various stipulations that, you know, that the life of the mother, those other carve outs. But in a given year, most recent years, the average is 0. And this funding itself, when we talk about specifically prenatal delivery and postpartum care, none of these services are related to abortion.
Any further questions? All right, go ahead and make your comments, please.
Madam Chairman, this is a relatively minor comment, but on page 2, line 8 of the bill, the not to exceed 105% of the healthcare provider's usual and customary bill cost. Almost all of our systems are set up to either ignore billed cost or to do 100%, which is basically we won't pay more than we are billed. So this 105% would be a pretty expensive customization to our systems. To do not to do 105% of Medicare, we can absolutely do that on a fee schedule, but to do this secondary calculation of not to pay more than usual and customary, generally the bills have always set that at 100%. This, I think, maybe is just a copy error to copy the 105 down to the 105. But if that was set to 100%, bracket 100%, that would be very helpful to us to avoid having to customize our systems.
All right, thank you. Do you have any other comments?
Madam Chairman, no, thanks for the time.
Okay, nope. I have one question for you. How many critical hospitals do we have in the state of Wyoming that deliver babies? Critical access hospital, I should say. Do we know?
Madam Chairman, I don't have the number right in front of me. We can get it within minutes.
Okay, not a problem. Okay. Thank you, guys. Dr.
Morning,
Beveridge, good
Madam
morning.
Chair. Thank you, committee. My name is Jacques Beveridge. I am OBGYN practicing here in Cheyenne. Wyoming native, practiced my entire career in the state, and also a committee member of the governor's task force specific to maternal health. Here just to speak on and in favor of this draft and the concept. It's one of the concepts that came out of the committee and that we spoke about at the last committee meeting. I think it helps in a number of ways, and I just wanted to point out a few of those. I think retention and recruiting of OBGYNs, really all physicians, but specific to OBs in the state is really challenging. And I think this it takes a step in the right direction of helping. I am not sure that the 5% is enough. And I would encourage to look more at a higher number, potentially looking back at like what was done during the special session 10 or so years ago. I think it goes a long way for these critical access hospitals. We'll find out what that number is and how many of those hospitals, but a lot of those hospitals also employ and retain those physicians. So it helps them to also retain those physicians, but also the healthcare team that take care of these pregnant moms and the newborns. I also think specifically this really helps our family practice residencies, both in Casper and Cheyenne. They proportionately take care of a lot more Medicaid and do a higher percentage of Medicaid deliveries than the rest of us. Most places it is about that 30 to 35%, but they tend to serve a lower income population. They have a higher Medicaid. So I think it would go some distance in also helping them. And they're, doing a good job of trying to help us train up these residents. And we're hopefully getting some of those residents interested in OB and hopefully staying in the state. We're focusing on that. And I think if we can keep these facilities open, and potentially if we're providing some prenatal care services in some facilities that even aren't doing deliveries, it is keeping that prenatal care close to home. And like we heard from the Primary Care Association, I mean, there's a lot of risk factors that go up when patients don't get prenatal care. And I think we create a hurdle if we're making these patients travel a long distance to get their prenatal care. So I think it can help there. I think the other, potential addition or amendment, call it what you will, that we might think about is specific to pediatric care. I think maybe Representative Ottman asked about that, but someone asked if it covered pediatric care. This draft does not. And realize, we have two patients here, not just the mom. I mean, that baby delivers. And a lot of these facilities, I think, are also closing because they're not just supporting the OB or the FPOB in the community, they're also supporting the pediatric care. And so we have to have the providers also to care for those newborns. And if we can keep those newborns in state, many of them preterm, maybe we don't have to have the real significant costs that Medicaid has to cover once they go out of state. Those are my first thoughts. I would answer questions if anyone has.
Questions? Representative Ottman and then Senator Scott.
Thank you, Madam Co-Chair. Just a quick question. One, if you could repeat your name, and secondly, with your working group or the governor's task force, have you talked about the requirement to have 3 doctors in order to have the malpractice insurance, and what we might be able to do with that, to work with insurance companies, to work with providers, or to eliminate that brick wall?
Certainly. Madam Chair, Representative Ottman, thank you. My name is Jacques Beveridge. Thank you. It's both are confused and commonly misspelled, so thank you for asking. The committee specifically has not looked at that proposal of requiring 3. And so the first 10 years of my practice were in Lander. I practiced solo practice. Part of the reason I'm now here in Cheyenne with 5 other partners. You can only do that so long. I don't think it's reasonable to have 3 physicians in some of these facilities. I mean, it'd be great. Some of them just can't support that. So many of them, though, to supplement that are bringing in locum tenens docs. For example, I think there were 2 providers in Wheatland, and they would bring in locum tenens, and I myself would go to Wheatland maybe once a quarter and cover a weekend or a few days of the week for them. And so that's the other answer, is bringing in other help. There's different models for that. It's a long answer to the question. I don't know if you had another one. I'm sorry. Thank you.
Madam Chairman, from what we heard in the rest of the testimony, what I'm taking home is the problems in getting obstetric care in Wyoming are inadequate reimbursement and it's inadequate because the volume of deliveries and patients is going down. And that's a problem we're seeing right across a lot of our healthcare. But decline in the volume, for which this bill does provide a remedy by increasing the rates, and the malpractice issues. Am I right in thinking that those are the 2 principal causes of the trouble we're having in the state on getting adequate obstetric service across the whole state?
Madam Chair, Senator Scott, I do agree with you. I think that is one of the major issues. The delivery rates throughout the country are going down. Wyoming's not different than the rest of the country. The only places we've really seen increases in the state are where patients are migrating from other facilities there. But overall, year after year, we're delivering less babies in the state. So it becomes harder for those facilities, especially rural facilities that already have low numbers and are seeing lower numbers and lower reimbursement. Their expenses don't really change to maintain that portion of their physical plant, to maintain the support staff, the pediatric staff, everything that surrounds that, the operating room, et cetera. So you're correct. I think there's other pieces to it. I think there is a trend in physicians entering practice to maybe not work as hard and think about their lifestyle. And people are more interested in those types of lives, I think, since the pandemic. And maybe that's smart. Maybe, practicing 10 years solo practice in Lander wasn't the best thing for my health or my family. There's a reason I changed, and that's hard. And people can only do that so long. And so I think that's a piece of it as well. I think we're finding, number one, it's a hard recruit to Wyoming. Number two, physicians often aren't as interested in being on call 24/7 every day of the year.
Representative Yen.
Madam Chairman, thank you. Dr. Beveridge, I also think about whether 10 years doing this job is too long as well. I'm curious, so let's pretend I know what locum tenens means and the rest of my committee doesn't. What would you tell my committee what locum tenens means? Is it like a traveling nurse?
Madam Chair and Representative Yin, you're exactly right. It's a traveling physician that temporarily fills in somewhere. And many of the hospitals around the state are using hired temporary docs to come help. I mean, we're not immune to that even in Cheyenne and Casper, the two biggest, care delivery systems in the state. But definitely in the smaller communities, it's happening a lot. And that comes at a higher cost as well. I mean, generally, they're losing money on those physicians, but the other alternative is to stop providing the service.
Any further questions? All right. Oh, Representative McCann.
Thank you, Madam Chair. This is probably more of a statement as opposed to a question, but I don't know what it is for physicians, but for like traveling nurses, traveling PAs, the travelers get paid a lot more, and that's why they do it. So, but then the hospital will try and hire them, but then they want to knock their pay down. So has there been any discussion on, because that just doesn't make sense to me. I mean, if you give that money to the people that live there, they might stay. So I just kind of wonder about that. Has that ever been discussed?
Thank you, Madam Chair, Representative McCann. I think so. I think your assumption's correct. I think the differences in those pays for traveling nurses is a little different than the traveling physicians, but it often happens. And many times those physicians are mostly interested in traveling, and they'll come to that community for a while, but they're not necessarily interested in practicing in that fashion for an extended period of time. And I think that's, to answer Representative Yin's question about what one thing would you pick, to me, as I thought about that, I was trying to think, if you asked me that, what am I going to say? And in the end, really, there's not one thing. Like, the committee's looking at a bunch of different things, and there are some maybe to recruit those physicians to stay in those communities, but I think it's why we're looking at it here, and I think there's a multitude of answers and possibilities, and we gotta do all of them. But just like at the special session, that really was more aimed at helping docs pay their insurance rates. In fact, I went through that, and I lived in Lander then. I came down, I testified, and I got the question, well, if we just literally, the question was, if we pay you more, won't you be able to pay your insurance? And my answer was, well, yeah, but that doesn't really fix the problem. But that's where we ended up. They paid more. And I think this is a piece of it. We can pay physicians more, we can pay hospitals more, but we still have to look at the many other pieces of it and the physician lifestyle to live in some of these small communities, and how do we keep them from burning out? How can we keep a lot of it pediatric care, can we keep it in the state? I mean, there's a number of things to do.
Thank you, Dr. Beveridge. I think you've summed up a lot of what I see out there with medical stuff and burnout. My mom's a nurse. I thought about being a physician, and she discouraged me from it, and she was right to do so. So I get to leave at the end of my shift. And so thank you very much for summing that up. On the medical malpractice insurance, one of the questions that I've asked that nobody seems to have an answer to, but I think you might. Do you know what kind of the average cost of medical malpractice for OBGYNs is currently? How much you're paying a year?
Thank you, Madam Chair. Yes, so I've seen a couple different verbiages circulated, and being mentioned as any like $50,000 to $65,000 a year, and I think that's probably pretty accurate. If that answers your question. There also was a question earlier that referenced laws surrounding insurance requirements. So if I could speak to that or give what I think is the answer to that.
Please.
So I think that law is strictly a minimum insurance required for those providing the care. For example, even on your a car liability insurance, there is some maximum there. So that's what those numbers are. The physician has to carry a minimum of 50,000 per incident or 1 million per year. Most physicians carry more than that, but that's the minimum requirement. Realize that's different than the idea of caps. There are no caps in Wyoming other than if you're covered by Federal Tort Claims Act. But otherwise, you could carry as much insurance as you want. But at the maximum, your insurance company is only going to cover you to that amount maximally.
Thank you. I knew we had a physician in the room that could answer that question. All right.
Good morning, Madam Chair, members of the committee, Sheila Bush with the Wyoming Medical Society. Dr. Beveridge covered the bulk of what I would have said. I want to just formally say that the Medical Society is in strong support of the bill in front of you. We see it as a stabilization measure and would echo everything that Dr. Beveridge said, that the solution to this will be a team effort and we'll have a multitude of things that we're going to have to do, and some will make baby steps and some will make larger steps, but they all kind of are envisioned to work together to try and move the needle a little bit on this issue as best we can. I also wanted to come up, and there were several questions, Senator Scott, that you asked in relation to tort reform and medical liability. I think you were at one point referencing the medical liability compensation account. Is that right? I'm mostly here to clarify what your questions were and offer that I can go research and try and get you answers. I just wasn't sure exactly what you were asking.
I'm not quite sure which question.
Okay. Madam Chairman, if you think of those, Senator Scott, I know that we discussed a little bit this morning that medical liability account, and it is not funded. It was envisioned to have a board that would run it. I think it was based on surcharges to physicians. So the idea was physicians would contribute money into that account, and then they could access funds in that account to pay claims.
Right. My understanding there that account has never proved useful and we've never used it.
Madam Chairman, I'm not sure if we know if it's useful or not. I'm not sure it was ever really enacted, or I don't know if it was given
Never
enough life to determine if it has usefulness. But you are correct in that I don't think that it was ever like really brought into fruition.
Yeah, and it was, I don't know when, Madam Chairman, it's first enacted, but it was before my time in the legislature, so it's been a while, been there around a while.
All right. Thank you. Yes, Representative Costin.
Thank you, Madam Chair. Thank you, Ms. Bush. Just if you can refresh my memory, 2023, we extended postpartum coverage from 60 days to 12 months.
Mm-hmm.
Did that cover mother and baby or just mother?
Madam Chairman, I would have to phone a friend in the Department of Health. Eric, do you know? We think it's just mother, but we obviously don't have a lot of confidence in our answer.
Okay,
thanks.
Thank you.
Hi there. Thank you, Madam Chair and committee. My name is Micah Richardson. I'm with the Wyoming Women's Foundation at the Wyoming Community Foundation, and we are a grant-making and advocacy organization that works for economic self-sufficiency for women and opportunities for girls. A lot of what we have thought about has already been stated as well, so I'm going to try to keep this real short. As we continue to hear about OB delivery services shutting down across the state, we feel like this bill is really going to be helpful to kind of shoring up some of those closures. It won't fix everything, as others have said. It's going to take a number of programs and policies to get us moving in the right direction, but this certainly is one that is beneficial in terms of the costs that providers and hospitals incur. And so we so appreciate you taking the time to look at this issue today and thinking about a number of different avenues to help maternal health in Wyoming, and are just grateful for it and hope we can be helpful as y'all move forward. So that's it. Thank you.
Thank you.
Madam Chairman, committee members, Eric Boley with the Wyoming Hospital Association. And I hadn't really planned on
testifying on this, but I feel like it can add a little bit of context. And it's also good to see the doc. I don't think I've seen him since we were at the AC/DC concert together a few years ago. In answer to one of the questions, we have 9 critical access hospitals that are delivering babies right now. And that's 9 out of 19 critical access hospitals. We've had a couple recently that converted. Evanston Regional converted critical access. Sweetwater County converted to critical access, and that includes those in this count. What I would say on this particular bill is I think this is one opportunity to work on a much bigger problem and a bigger process. I would tell you that I think this is an important bill if we want to sustain what we currently have, but it will not fix those that have closed. There's no way. We've already talked a lot about the fixed costs that are involved, and I've heard from some of my other critical access hospitals. I have one in particular. They do not have 3 OB or family practice docs that deliver, and so they rely on 2 of those to take call pretty much 24/7 and rotate it between them. Their fixed costs alone, just to pay on-call time, whether a baby's delivered or not, is well over $250,000 for one physician to take call. So I don't know exactly how we cover that cost unless we want to pump some more money into the system, which is really what we need to do. I think the other thing that needs to be addressed here too is economies of scale. When we think about deliveries, we think about the simple deliveries, right? We think about things going exactly the way they're planned, baby being delivered in 24 hours, mom stays for a couple, 3 days, baby and mom go home and they have their follow-up. We have to be ready for every contingency, everything that may or may not happen. Some of our providers aren't comfortable with doing regular delivery after a C-section. Some of them are not really well trained in some of the things that could go wrong. And we have other support staff that we have to consider. So this is a very complex issue. I think we've touched on another really important thing when we talk about the insurance side of things. We're talking about what an individual provider, if they're in private practice, pays for their malpractice coverage. But hospitals employ and we cover malpractice for about 40% of the physicians in the state. And so that's factored into our malpractice insurance. And Senator Scott remembers really well, because we've been through a lot of this together. There was a time when we could not get malpractice insurance in our state, and he's recounted that. The Wyoming Hospital Association actually went out and we partnered and we built our own malpractice insurance company because there were no other options. And that's not really one of the areas that I thought we needed to be in, but it's proved to at least offer some options to some of our hospitals. So I guess in reference to this particular bill, I think this is a good start, but it's not going to fix all the problems. The other thing you should be aware of, there are statistics out there showing that by 2036, I believe, we're going to be short over 200,000 family practice doctors. We're going to be short over 750,000 registered nurses and LPNs. So what we're seeing right now is just the beginning of issues that we're going to see in the future when we try to recruit providers and have them have the lifestyle that they want and come to our rural communities. And so I think there are some really innovative ideas. I think that we might be able to come up with some other ideas as we use the $50 billion that's coming out through the Rural Health Transformation Funding. And as we've met with the Department of Health, we've talked about some of those ideas. But in reference to this particular bill, we're in support of it. I think it's a Band-Aid, and I think it'll help at least sustain what we have in our communities that are currently delivering babies. And with that, I'd answer any questions.
On the 40% of physicians, you say, is that 40% of all the physicians that are practicing in state? Or is it 40% of the ones doing obstetrics? Is there a difference in that percentage?
Madam Chairman, Senator Scott, it's 40% of all. I'd have to really do some deep digging. And there are different hospitals with different philosophies. Some will only allow OBs to deliver. Some do allow family practice. Some do allow others, but we'd have to dig a little bit deeper to figure out exact numbers if you wanted us to.
Representative Clouston.
Thank you, Madam Chair. Mr. Boley, if you could refresh, this happened before me, but Wyoming used to have a medical review panel. And in some states, that helps lower liability costs that you talked about. Can you give me a little background on why Wyoming got rid of our review panel?
Madam Chairman, Representative Clouston, from my recollection, we tried to enact it, and it had limited results. I think one of the biggest problems, though, was it was hard to find people to actually serve on that, that could separate themselves and create that unbiased peer review. It just really never took off, and it just kind of has faded. I'm not even sure why we quit using it, except for the fact that it just wasn't widely used in these cases. And I think Representative McCann did a great job. A lot of these things are just settled. It's easier for the insurance companies, and I don't agree with it particularly, but trials are very expensive and time consuming. But I just think over time it's fizzled out. It just wasn't really effective.
Any further questions? Representative Ottman.
Thank you, Madam Co-Chairman. Mr. Boley.
Hi.
Hi. I was just wanting to ask, do you see any effects of scheduling of C-sections by physicians? I've heard that since there is a shortage and with different things, that they are actually scheduling. In a way that seems like a good idea, because then you could know when this woman was going to have a child. But on the other hand, I've also heard that creates a lot of complications. Have you seen anything like that in the hospitals?
Madam Chairman, Representative Ottman, I'm not aware of situations. I know people like to, I think there are times when we may have physicians, when the baby is carried to full term, when they might talk about inducing labor. I haven't really heard where they're actually scheduling C-sections to deliver the baby because of scheduling. I don't think that physicians would really want to go down that path, because that's not, but I'm not aware of any, would be my answer.
Other questions? All right, any more public comment? Do we have anybody online?
No, Madam Chairman, nobody has raised their hand.
Okay, so here's what we're gonna do. If you look at our schedule, we're way behind, but there's no such, the healthcare just is not simple. So we're gonna take about a 10-minute stretch/bathroom break, and we'll come back. LSO is gonna go through the rest of the bills with us. We'll take public comment and then on the bills, and then we're gonna work the bills as the committee. That's my plan right now. Thanks for your patience. This is the first interim committee that I've chaired. So about 15 or a 10-minute break, sorry. And also the Highway Patrol wanted me to let you know that somebody is parked on a triangle. Okay. Never mind, I will not, we've got it figured out. So we'll take a break, refill your drinks, bathroom, and then we'll get back to work.
Committee members, we are running 5 minutes behind from the scheduled break, so we're going to move forward. I'm not sure where good co-chairman is, but for the sake of time and the number of bills, draft bills on the agenda, we'll go ahead and keep progressing until the good co-chairman returns. All right, so where we left off was Bill Draft 26 LSO 0134 Medicaid rate increase obstetrics services. I believe we concluded public comment with online, correct? Okay. So with that, we will close public comment and continue to move forward on that bill draft as the good co-chairman mentioned before our break. So committee, what is your pleasure on the bill draft?
Move the bill draft.
Senator Scott, moved by Senator. The bill's been moved by Senator Scott.
Second.
Second by Representative Yin. Discussion on the bill draft amendments. Senator Scott.
Madam Chairman, I think this is a critical bill. We all know we're having major problems right across the state. I think the bill does need some work. And I don't think we aren't going to have another meeting, so I think we're kind of stuck with what we've got. I do think we need to broaden the title, Madam Chairman, because we're going to have to look at more than just physician services. You've got nurse midwives and other providers we need to think about. We need to think about all the hospitals and not just the critical access ones, Madam Chairman, because some of the non-critical access hospitals are having trouble keeping OB services. So I do have an amendment if, when you're ready for them.
Please, Senator Scott.
Okay, on page 1, and this is in the title, page 1, line 3, delete the word physician and delete the word and critical access hospitals. So it would read for increased reimbursement for obstetric services under the et cetera. So we just make the title broader.
Okay. Any second on the amendment, committee?
Second.
Seconded by Representative Clausen. I apologize, Senator Crum. I forgot you're on virtual there. We do have a second within the room, Representative Clausen. Committee discussion on the amendment.
Madam Chairman.
Senator Scott.
Madam Chairman, strictly trying to, the title is going to constrain what we can do at session and trying to make it a bit broader. So as this bill goes through, we hit some complications with some of the things that aren't covered in the title. We'll now be able to cover them. The bill will be broadly on the issue of reimbursement for obstetric services.
Further discussion on the amendment. Okay, any online? Okay, seeing none. By a show of hands and a voice vote, all those in favor of Senator Scott's amendment, please state aye.
Aye.
All opposed?
No.
No. Okay, that amendment has failed. Division being called. All those in favor of Senator Scott's amendment, please, by a show of hands, raise your hand. That's 5 ayes. All opposed? 8 noes. The amendment has failed. Further amendments on the bill draft. Representative Clouston.
Thank you, Madam Chair. On page 2, as discussed by the department, on line 8, it reads to exceed 105% of healthcare providers' usual and customary bill costs. I would like to change 105% there to 100%, so we're not paying for more than what we're actually being billed.
Would you like to move that, Senator Clausen?
I would. I'd like to move that, Madam Chair. Thank you.
Thank you, Representative Clausen, sorry. Seconded by Representative Yen. Discussion on the amendment. Okay, seeing none or none online. By a voice vote and a show of hands, all those in favor of Representative Clausen's amendment to change it from 105% to 100%, please state aye.
Aye.
All opposed? Okay, that amendment has passed. Committee, further amendments. Okay, further discussion on the bill draft. Representative Yen.
Thank you, Madam Chairman. So I don't think this will fix it, right? I think as Dr. Beveridge talked about, all of these are part of a solution, but what we need to do, frankly, is staunch the bleeding. And I, hearing that list from the Department of Health where we've been losing labor and delivery services since 2018, every single, almost a service, one county per year, one hospital per year is not a good path for Wyoming. So supportive of the bill just to keep us from losing the existing services that we have.
Further discussion on the bill draft? Okay, seeing none, sensing the urge to vote. Roll call on bill draft 134.
This is a roll call vote for 26 LSO 134 Medicaid rate increase obstetric services as amended. Senator Crum,
Aye.
Senator Hutchins,
No.
Senator Scott,
Aye.
Senator Steinmetz,
No.
Representative Clauston,
Aye.
Representative Gugemas,
No.
Representative Heft, Representative McCann, Representative Ottman, Representative Thayer, Representative Wasserberger, Representative Yen,
Aye.
Co-Chairman Rodriguez Williams,
No.
Co-Chairman Brennan.
Aye.
6 aye. Mhm.
What was it?
And 8 no.
Okay. 6 aye and 8 no, so that one fails to pass. Okay. LSO, if you would go ahead and present us the rest of the bills in this maternity care, maternity desert section.
Yes, Madam Chairwoman, and would you like me to pause for committee questions between each one or wait until the end?
Committee, do you have a preference? Probably committee questions on each.
Okay, that
each
works.
one. That way we can keep our heads straight.
Sure, that works. All right, Madam Chairwoman, members of the committee, we are on Bill Draft 26 LSO 136, Wyoming Pregnancy Centers, Autonomy and Rights. And so beginning on page 2 in section 1, there are legislative findings that continue on until the beginning of page 4. And then starting on page 4, we have several new statutes that are created. The new Wyoming Statute 139-125 provides that a governmental entity is liable for damages resulting from the newly creative Wyoming Statute 35-4-1103, which is created by this draft. In Wyoming Statute 35-4-1101, it indicates that this newly created act shall be known as the Wyoming Pregnancy Center Autonomy and Rights of Expression Act. Beginning on the bottom of page 4, definitions of abortion, abortion-inducing drug, contraception, ectopic pregnancy, miscarriage and stillbirth, pregnancy center, pre-viability separation procedure, and this act are provided. And then beginning on the bottom of page 7, it is indicated that the state and its political subdivisions shall not require a pregnancy center to offer or perform abortions, offer or provide abortion-inducing drugs or contraception, refer a person for an abortion, counsel in favor of abortion, post any advertisements that promote or provide information about obtaining an abortion, prohibit a pregnancy center from providing information about pregnancy, childbirth, or parenting, prohibit a pregnancy center from providing prenatal and postnatal resources, prohibit a medical pregnancy center from providing medical testing and counseling, prohibit a pregnancy center from counseling about pregnancy-related care or treatment, or interfering with a pregnancy center's staffing or hiring decisions. And then beginning on page 10, a pregnancy center or any person aggrieved by a violation of this act may commence a civil action, and a person prevailing in an action shall be entitled to recover an amount equal to 3 times the actual damages sustained. Recovery under this subsection shall be not less than $5,000 and shall include all costs and reasonable attorney fees. The legislature may appoint 1 or more members to intervene as a matter of right in any case in which the constitutionality or legality of this act is challenged. And then section 3 on page 11 provides a conforming amendment, and section 4 on page 12 provides an effective date, and I would be happy to answer any questions.
Committee, any questions for LSO on this?
Madam Chairman.
Yes, Senator Scott.
Madam Chairman, there's a number of features here that don't look like normal Wyoming legislation. Is this a national bill that has been copied? Where did this draft come from?
Senator Scott, this is a resurrect. I didn't have the original bill. I can answer that question for you in probably about 5 minutes, but I'm pretty sure it is a national bill that's been introduced in several different states, from what I recall. So.
Any further questions for LSO on this draft? Okay. We can go on to 26 LSO 138, Medicaid birth cost recovery repeal.
To recover Medicaid birth cost from biological fathers of babies whose birth costs were paid by Medicaid. There's a conforming amendment on the top of page 2, and then the staff comment beginning on page 2 provides the statutory language that's being repealed, if you'd like to review that. And then section 3 on page 8 provides an effective date, and I would answer any questions.
Thank you. Any questions for LSO regarding the draft on Medicaid birth cost recovery and repeal? Representative Yen.
Madam Chairman, just because it came from me, I'll provide some comment on it if that's appropriate. Yeah, so just briefly, again, this is a bill draft about legislation that was put, I think, in 2018, where we basically try to create a bureaucracy that tries to squeeze blood from a stone, where we force women to write down the names of and contact information of the biological father, and then try to go after the biological father, thinking if they have funds available to reimburse Medicaid if for some reason that they were committing Medicaid fraud. We've lost money over time because the cost of those court cases has always been more than the cost of recovery generally, and I'm sure the agency will bring it up if they do provide comment on it as well. So those are the comments, just a cost-cutting bill.
Thank you, Representative Yen. All right, we can go on to birthing centers Medicaid coverage.
So this bill draft is a very simple draft. It is entitled 26 LSO 162 Birthing Centers Medicaid Coverage. And this bill draft essentially provides Medicaid coverage for birthing center services. And that is basically the entirety of the bill.
Any questions for LSO on this bill?
So Madam Chairman, if I may,
Yes, please,
just to
Representative
provide context on both of this bill and the next one as well. We basically have 2 new birthing centers in the state for which was a business that literally didn't exist in the state before. Under CMS, I think we're actually required to fund birthing centers, but we never had it in statute regardless. So this basically puts it in statute where freestanding birthing centers would be covered by Medicaid and would be covered for the next bill by private insurance in the same rate that for the exact same services that another facility would be covered.
Representative Ottman.
Yes, Madam Co-Chair. Representative Yin, if you could give me the statute that requires by law that they are funded, I'd appreciate it.
Madam Chairman, I think it's actually in CMS federal rules and regulations that states are supposed to fund that. I think that was in the passage of the ACA. I would need to ask Department of Health to help back me up on that one. And maybe I'm wrong, but I'm pretty sure that's the case.
And Madam Chairman, Representative Ottman, I can look that up real quick too.
That'd be great if you want to look that up. Okay. So those are the 4 bills that we have left in this section. Could I get a show of hands on who is here to testify on the Wyoming Pregnancy Centers Autonomy and Rights Bill? Oh, sorry.
We have one more. Sorry.
Oh. Okay, go ahead. I'm sorry. I
That's all right.
didn't see it on my list.
This final bill draft under the maternity topic is entitled 26 LSO 237, Birthing Centers Insurance Parity. So Section 1 on page 1 creates Wyoming Statute 262901, which requires health insurance companies that provide coverage for maternity care and newborn care in a hospital setting to provide coverage for maternity care and newborn care in a birthing center. Covered services include services of licensed midwives and other licensed healthcare providers practicing within their scope of practice. And coverage provided under this section shall be provided at no less favorable terms, conditions, and reimbursement rates as coverage for comparable maternity and newborn care services in a hospital. Section 2 on the bottom of page 2 indicates that this act shall apply to all health insurance policies delivered, issued, renewed, modified, amended, or extended on or after July 1st, 2026. And Section 3 on page 3 provides an effective date.
Right. Any questions from the committee on this bill for LSO? And thank you for keeping me straight, you guys.
Madam Chair, just want a little history on this from whoever requested it, just a little bit more.
Madam Chairman, again, so we had the testimony from the birthing centers at our last meeting. And it was a question of how do we make sure insurance covers them, because facility fees are covered under insurance for hospital births. It didn't make sense for it not to be covered under in a freestanding birth center for the same facility fees. And so this is just parity under insurance law to make sure both freestanding birth centers and hospitals get covered for the same services.
Senator Steinmetz.
Thank you, Madam Chairman. I guess I would just have some questions. One, what are the costs expected with all of this, all of these changes? And 2, it looks like many of these bills relate back to a previous administration's policy on how they wanted to handle this. And so I would like to know what changes are coming out of the current administration and how, if they're still supporting all of this, because it kind of looks to me like we're trying to implement a previous administration's policies at the state level. Thank you.
Madam Chairman, if I may. Yeah, I have no idea under which administration considers what for midwives. I don't follow federal midwifery policy. I do know that births under midwives just tend to cost less overall. And so when we have births in birth centers with midwives, it generally will be, frankly, because it's less services overall, the costs will end up being less. But I again, don't know what any federal administration does about midwives, because again, I don't follow federal midwifery policy.
Representative Clauston.
Thank you, Madam Chair, and to LSO or to the bringer of the bill. I'm not really familiar with birthing centers and them being new in Wyoming. How are they licensed in Wyoming?
So Madam Chairman, I hope we can get the Department of Health to actually answer some of these questions, but there is licensure for freestanding birth centers. Again, we've never had one before, so they've never needed to be licensed before because we've never had one. But I believe when some of the folks who testified with us last meeting, I think they are going through the licensure process with the Department of Health right now.
Any further questions on this? Okay, I will just comment that we were trying to make or effort to make all of this one bill, but realized that these probably needed to be two bills, and that's why you see two bills on these birthing centers. So I'll just comment on that. All right. Thank you. Now I'll take a show of hands on how many are here to testify on the Wyoming Pregnancy Center's autonomy and rights. Okay, so we have 20 minutes before we break for lunch. So if you guys would come forward and if you can keep your comments to 2 minutes or less, that would be great. Yes, and we are going to time these. So, and go ahead and you guys can just come fill up the chairs. All right. If you guys would state your name for the record and then provide testimony.
Hello, thank you, Madam Chairman and committee members. My name is Britt Borrell. I'm the Executive Director of WYO United, a nonpartisan organization that seeks to protect and advocate for reproductive health care access for all Wyomingites. I do have major problems with the so-called CARE Act that is being proposed. The name alone is indicative of the shady naming conventions politicians like to use to obfuscate the harmful material in the bills being discussed. This bill in no way promotes care for pregnant women and girls. In fact, it aims to shield unregulated pregnancy centers from oversight. To be clear, these centers are not licensed healthcare providers. They are not required to be staffed by licensed medical professionals, nor are they required to provide accurate and comprehensive medical information to people seeking their services. Personally, I would not want an unlicensed volunteer giving me an ultrasound, particularly when I know that they have an express mission of scaring women away from abortion and have been known to mistake pregnancy start dates in an effort to convince women that they are too far along in their pregnancy to seek a medication abortion. But that's the problem. I know these things about unregulated pregnancy centers, but the broader population and the women and girls that these centers target with their misleading advertisement largely do not know that they are not going to receive comprehensive health care. In fact, these centers explicitly target people who are most likely to seek abortion. Perhaps most worryingly of all, because these centers are completely unregulated, they do not have to adhere to HIPAA, meaning they could share sensitive private information about the people who visit these centers with their faith groups, law enforcement, or maybe even unintentionally by storing these sensitive data in an insecure manner. I don't believe these centers should be forced to provide or refer abortion services. I do not protest their free speech in advocating against abortion, but I do believe that they should be required to state plainly that they are not licensed healthcare providers, do not have to adhere to HIPAA, and be extremely upfront in the fact that they advocate firmly against abortion. If people still seek them out with full knowledge of the care that they are likely to receive, excellent. But the first step in making informed care decisions is to be fully informed. So please abandon this misguided bill. It in no way helps us solve our issues with the maternity care deserts that I know we have a shared desire to alleviate. Thank you.
Thank you. Committee, any questions? Senator Hutchings.
Thank you, Madam Chair. Ms. Britt, can you tell me where you're getting your data?
Which data, or sorry.
Any and
Madam
all.
Chairman.
Thank you.
There's multiple resources from the AMA, from the American College of Gynecologists. A lot of our research, I think we sent out in a packet to LSO that should have been distributed to all of the committee members and sourced appropriately.
Thank you, Ms. Broyle.
Thank you.
Good morning, Madam Chairman and Joint Committee. I am Emma Laurent, and I drove down from Sheridan to be with you all here today. I would like to speak against the proposed CARE Act. This is not a solution to fill the maternal care deserts in Wyoming. First and foremost, as Senator Scott pointed out, this is not a Wyoming bill for Wyoming solutions. The first section overall, much of this bill is preamble and overture. It's not standard lawmaking language, and this could be pointed out in any high school government classroom. These are not facts, these are opinions. Regardless, though, of how anyone in this room feels, though, about the act of abortion, what every single person in this room agrees upon is that if a woman chooses to have a family, that choice should be honored, and that's the state should do everything in its power to usher in a healthy family. So what I don't understand is why you would waste a single precious cent of taxpayers or the government's money in propping up a fake clinic where Wyoming women and girls have gone on record of having to give themselves a non-medically needed transvaginal ultrasounds to satisfy the request of a non-medically trained volunteer who then stands and lurks in a corner until the client is done. And I emphasize the word client because legally, unregulated pregnancy centers are not medical clinics who cannot provide any type of prenatal care to a woman or her growing fetus. Can they test a woman for strep B? No. Can they treat a woman who thinks she's having contractions and instead turns out to be Braxton Hicks? No. Hemorrhoids? No. Or a miscarriage, otherwise known in the medical community as a spontaneous abortion? No. And certainly nothing to do with postpartum. I urge this committee, regardless of your politics, not to waste any more breath on this bill. Its entire purpose is to pit two factions against each other and divide you against the Wyoming people and what they actually need, which is comprehensive health care with medically licensed and trained staff to take care of women and a new life they choose to bring into this world.
Ms. Laurent, we're at 2 minutes, so if you could wrap up, that would be appreciated. Thank you.
I understand, Senator Brennan, but I have tried to reach out to every single member of this committee. I've even driven to your co-chairwoman's hometown where she declined to meet with me. So if I cannot speak here, and I know many folks in this legislation are not even checking their emails, when do I get to speak?
If you could just finish up your comments, that would be great. Thank you.
So I urge you to stop spending your energy on the theory of the sanctity of life and actually support increasing practical solutions, such as expanding birthing centers and attracting OBs to the state to take care of women, Wyoming women, and the tangible health and any subsequent children they choose to have. So set aside these buzzwords and actually be heroes for the women of Wyoming. Thank you.
Thank you. Committee, any questions? Okay.
Good morning, Chair, members of the committee. My name is Sophia Gomelski, and I've lived and gone to school in Wyoming for all 19 years of my life, and I'm here today to speak in opposition to this bill. I think it's important to be clear about what this bill does. It claims to protect pregnancy centers, but what it actually does is shield unregulated organizations from accountability, while simultaneously restricting the ability of the state, counties, and cities to provide accurate science-based information to the public. These centers strive to give the impression that they're clinical providers, offering medical services, counseling, and abortion pill reversal treatments, yet they're not licensed healthcare facilities. They're not subject to the same oversight credentialing or ethical standards that apply to doctors, nurses, and legitimate medical clinics. They're free to operate with minimal transparency, even while making deeply personal and consequential decisions and recommendations about pregnancy, contraception, and abortion. Because the ideology of these centers is allowed to take priority over evidence-based medicine, women are not guaranteed accurate information about all their options like they deserve. Instead, they're often met with misinformation, shame, and pressure to continue pregnancies, even in cases where that may endanger their health, safety, or dignity. That's not free speech, that's medical deception, and this legislature should be in no business of protecting it. I think it's also important to remember the context here, which is that for the past 2 years, we've seen the legislature refuse to pass a healthcare workers protection bill, which would have safeguarded licensed credentialed medical professionals from harassment and violence simply for doing their jobs. So when we talk about protecting the freedom of expression, we should ask ourselves whose expression really counts. The trained doctors, nurses, and midwives who are providing evidence-based care, or unregulated centers that are impersonating them. There's also another thing that we can't ignore, which is that abortion is still legal in Wyoming. The courts have made that clear, and no matter how anyone personally feels about it, abortion remains a lawful medical procedure in the
Gomeski,
state.
we're at 2 minutes again. If you could just wrap up. Thank you.
Yes, ma'am. I'll just go here, which is that as a young woman from the state, I've seen why young people are leaving. It just has more to do with jobs, and it has to do with the feeling of our leaders not trusting us or not allowing us to make informed decisions about our own lives. When we pass laws that censor accurate medical information or elevate ideology over science and the law, we tell young people that their autonomy and their future don't matter here. So if Wyoming wants to keep its next generation, it starts by showing us and showing people that you trust us to think for ourselves and to access real information to make our own choices. Thank you for your time. And I'm happy to stay and answer any questions.
Thank you. Any questions? Thank you. Oh, yeah. Senator Steinmetz.
Thank you, Madam Chairman. You know, it's always interesting to me how, thank you for being here today, and we're going to disagree, but it's always interesting to me how worried we are about the next generation, and yet we're killing the next generation. So what do you have to say about that?
Thank you, Chair, and thank you, Senator Steinmetz. I think, what's really important to recognize is that, and one thing I'm really proud of the state for doing, which is keeping abortion legal. And part of that is due to religious protections from a Jewish community. So I personally am Jewish, and in my religion, it's considered a fetus, or an unborn baby, is not considered a baby until has been birthed. And so there's no such thing as an unborn child, and certainly not in science. And so that isn't the next generation. I'm the next generation. I'm sitting right in front of you. And what I'm asking you guys to do is to protect us while we're here, the people that do here and the people that you really do serve now. Hopefully that answers your question.
Senator Hutchings.
Quick question, Madam Chair. Sophia, thank you again. It's always nice to see you. Have you been to a Wyoming Pregnancy Center and actually had someone walk you through and show you what they do and introduce you to the doctors and the programs that they have before and after a pregnancy?
Thank you, Chair. No, I actually have not, but that is definitely something that I'll look into doing. But I think the larger concern is that these pregnancy centers aren't required to do certain things, and that opens up a lot of risk for the women and girls in the state of Wyoming. And I think that, as the equality state, women deserve better. They deserve to be able to walk into a healthcare provider or a clinic and get the same kind of medically accurate information that a man would be able to. It's not fair that certain clinics just get an exception and they don't have to be held to the same standard. It's unequal treatment based on sex. Thank you.
Any further questions? Right.
Thanks.
Thank you. Anybody else in the room that would like to testify? Thank you for coming, and just as a reminder, if you'll state your name and we'll give you 2 minutes also.
I'm here on it as just a Wyoming resident, born and raised here, and I happen to be an executive director of a pregnancy care center. So I would like to address the fact that many people have said that we are unlicensed. We have a medical director who is a DO. We have a OBGYN that is retired here from Cheyenne that volunteers on Mondays. We have a family nurse practitioner, 2 registered nurses. And so to say that we are not a medical clinic is not true. We are a medical clinic and we are licensed unless the state of Wyoming needs to look at the licensures, that is false, that we are that. We grant full autonomy to our patients. And it's important to know that we discuss abortion, we discuss parenting, and we discuss adoption. And I'm wondering if those that are upset about this are discussing parenting with their patients. Are they discussing adoption? There are many couples and individuals in Wyoming that would love to adopt, but do not have the option for that because of abortion. And so I'd like to just address that as well. I'm a little bit concerned about the fact that we use the word reproductive rights when abortion is mentioned. That's not reproduction. Abortion is not reproduction. And so I just needed to put that out there. I would like to invite all of the committee, any one of you, to come to my center and take a look at how we discuss, how we have conversations with the patients when they come into our center. And they have full autonomy. We do not share anything with them unless they give us approval to do so. If they want to see something about abortion, we will share that. If they tell us no, we do not share that. And there is no pressure to do that. And so it is imperative that you understand that every one of the pregnancy care centers in the state of Wyoming have a medical director. So we do qualify as that, and we do perform ultrasounds by registered nurses. As far as this legislation, there are some others that would like to
Mrs.
speak
Berry,
towards that.
apologize, we're at 2 minutes.
That's fine. Thank you for your time. I appreciate it.
Thank you. Senator Scott and then Senator Hutchings.
Madam Chairman, I've got a question and it's going to be on the immediate need for the bill.
Yes.
And let me explain why I'm concerned about that.
Yes.
We're facing a budget session.
Right.
This is going to be a very controversial bill, probably with lots of amendments to it. Take a lot of time, and that's a problem in getting any bill through a 20-day budget session. The question I've got, the bill prohibits cities, counties, et cetera, from interfering with these pregnancy centers. Is there any current problems with cities and counties prohibiting these, vastly restricting them? Is this preventing a potential future ill, something we could deal with in a general session? Or is there a current crisis going on that leads this bill to come forward at this time?
Thank you. I was not involved in drafting this bill. I do know that in Cheyenne, we do not have anything that I'm aware of that would say that that is something that we're dealing with right now. I do think this is a proactive bill in keeping that because it is happening around the United States. And so I would say it's more proactive, but I believe there are some that I would refer to that will be online that could answer that question.
Senator Hutchings.
Thank you, Madam Chair. Valerie, question on how many women go through to have live births. It seems like we're talking about maternity deserts. How many women go through to actually give birth to their children?
Would you repeat that last part of your question?
Just how many live births do you have? We were talking about maternity deserts, and it seems like the pregnancy centers are actually helping.
Mm-hmm.
Can you give me a number of live births annually for Wyoming?
I would like to, we would have to get back to you on that question.
Thank you.
We have examined a lot that happens in Laramie County, but for the state in its entirety, I do not know. Thank you.
Representative Costin.
Thank you, Madam Chair. Thanks for being here. Quick question. We're going into this budget session. Are you all privately funded or do you receive some public funds?
Here at Life Choice, we are all privately funded. Yes, thank you.
Thank you very much.
Thank you for your time.
Okay. Go ahead, state your name and again, 2 minutes.
Thank you. My name is Charla Ricciardi. I moved to Wyoming in 2008, accepting a job at the Wyoming Department of Health in the Maternal Child Health Unit, where I was employed for 10 years. It was in the Department of Health that I learned to have a love for data and all things that are critical for why or how decisions are made. In those 10 years at the Department of Health, I served as the interim maternal child health director, the Children with Special Health Care Needs director for many years. And of course, because of a budget freeze or hiring freezes, many other positions, including early childhood and children's health. One of the things that I was blown away when I first walked into Life Choice Pregnancy Care Center 6 years ago was how different it was than anything that I had heard or what my conceptions, my preconceptions were about pregnancy care centers. I pulled a little bit of data and I wanted to let you know that just at Life Choice, we have done over 2,000 ultrasounds in the last 5 years. We've done over 1,700 pregnancy tests. And what we find is that many people with unintended and planned pregnancies are referred to us. We work closely with UW Family Practice. We work very closely with midwives in the area, Cheyenne OBGYN. We even get referrals, from the women's clinic because we do offer all of our services for free. There's no cost to the taxpayer. We are able to help identify if a woman is considering taking the abortion pill. A very critical thing that they need to know is that pregnancy in the uterus or is it an ectopic pregnancy? Because taking an abortion pill when you have an ectopic pregnancy can be very, very dangerous. And so what I saw is very high level professionalism, medical expertise, people being loved on. And I was amazed when I heard the maternal desert data because we have 11 pregnancy care centers. They're all independent, but around the state. When I was at Maternal Child Health, one of the things that we did was we provide specialty clinics. And I did a little search right now. MCH at the Department of Health provides 12 specialty clinic types of care in 13 cities around the state because access to care is important. But what we saw was a problem was having space for that. The public health offices often didn't have any space for some of those specialty clinics. What was a big aha for me was to realize that every one of these pregnancy care
We're at
centers
2 minutes.
have an ultrasound machine. They're set up to be able to see clients. And I think it could be a great thing to consider a partnership in addressing maternal health deserts if people are traveling to provide care.
Thank you. Any questions? Ma'am.
I'm so sorry.
You want to?
I'm so sorry.
That's okay.
Sorry.
Representative McCann?
Thank you, Madam Chair. Of those 2,000 ultrasounds that you did, how many, if you can answer this, were ectopic pregnancies?
Excuse me, Madam Chair, Representative McCann, I do not have that data. I didn't come ready with that. I do know that 1% to 2% of pregnancies do tend to be ectopic pregnancies, just in general. So it is a concern and it's a risk for women, but I can't tell you how many of these were. I do know of at least a few where a woman has been a walk-in, they've needed care. We've been able to reach out to our medical director, and this is just in the last couple months, who's been able to get her in to see a doctor immediately in the ER to be able to help triage and save her, her life and her health. So it does happen, but I don't have that data for you. But I would love to look into that further if you would like.
Thank you.
Representative Ottman and Representative Yen.
Thank you, Madam Co-Chair, and thank you for being here today. What we're often led to believe is that, and we were told here today, is that until there is a birth, that it isn't a baby. Isn't the ultrasound able to tell what stage and show exactly the development of that child, where they're at, and those things? And then also, did you say that everything is free to the clients? And then one last question. In our local pregnancy center, we also, or they also offer classes for families and stuff. And they're even working with the judicial system to help people that have had their children taken. So we've seen that they're working there in the community at no taxpayer expense or cost to the person. Is that true?
Madam Chairwoman, Representative Ottman, you are absolutely correct. I might answer those questions in reverse order since I remember that most recently, but yes, we do, everything that we do is offered free of charge. There's no cost to it. I can speak as 5 years as the education director at Life Choice here in Cheyenne, that we oftentimes will receive requests, referrals for parents to come and take our free parenting classes to then meet recommendations by DFS or by family court judges. We do, let's see, remind me please of the other questions you had.
The ultrasound and what that does show and what it doesn't. And also, I neglected to ask, but just to verify that the people that are doing the ultrasounds have gone to a specific training.
Yes, Madam Chair, Representative Ottman. Yes, anyone that performs ultrasounds, of course, must be involved in a very rigorous training, be certified for that. Our ultrasounds are to determine due dates. So I'm not an ultrasound technician, but from what I understand, that babies grow at the same rate of speed. Please correct me if I'm wrong, Senator Brennan, but that's why dating ultrasounds in the early stages of a pregnancy determine the due date, because it doesn't matter if the baby ends up being big or small. In those early stages, they can accurately determine. And we've had many clients that have said they go to their doctors a few months later, and boy, those due dates that we've given them are just really spot on. But we are able to see if it's a viable pregnancy, if there's been, if the baby has passed, if they're going to, have a miscarriage. We always give miscarriage signs and symptoms, things to look for, those kind of things. So all of our ultrasound are certified. It does show if the baby is viable. And I would say, I've heard a doctor speak and say that when you're going into surgery and the baby is needing some kind of pre-birth care for it, you have an entire medical team for the mom, but you already have an entire medical team for that preborn baby. And that very clearly in my mind shows that that is a baby if they have an entire medical team in the OR that's working on them as well in case anything happens. So, thank you.
Madam Chairman, thank you. Thank you for being here, both of you guys from Life Choice. Happy to take a tour. You tell me when. If I'm in town, I'll be here. I'll do it. I'm curious about the ultrasound data. Do you guys is there a policy? I mean, I know you guys are all independent, so maybe if you know about other pregnancy centers, what is the privacy policy around that data or any data that they give you? Since I mean, do you follow HIPAA compliance? What does that look like? What if you don't? What policy do you have?
Absolutely. Chairwoman Brennan, Representative Vian, we 100% follow HIPAA compliance. All of our ultrasounds, of course, because we have a medical director, are sent to the medical director in a HIPAA compliant way so that then he can review and sign off on those. So our nurses that are doing ultrasounds that have been certified, they always everything is confirmed by our medical director, and he is a well-respected local doctor here. I do not know how many years he's been there. I was curious of that. I don't know for sure, but at least the 6 years that I've been there, he's been the medical director. And recently we have been, I hope I'm okay to say this, we have been researching and looking into what it would take for us to become AAAHC. And so we paid for someone to come out January of last year and do a complete 2-day observation of everything we were do, all of our policies, everything, how it's, where our laboratory areas, all of that, to identify things that we would need to create policies, different things to go for AAAHC certification. So we absolutely are the highest medical care that we can provide. And it's really a partnership. It really is between the medical doctors in our area, nurse midwives. We're able to do ultrasounds. The midwives often refer their patients to us so that we can do those initial ultrasounds so that then they can get those back and continue on with their care. So it really is a partnership. Yeah. Oh, I wanted to say our tours of our center are the last Wednesday of every month here in Cheyenne at 11 o'clock. We do that before we open to the public, and we would absolutely welcome anyone that wanted to come and see what we do.
Madam Chairman, follow up, if that's okay. You said nurses are giving ultrasounds, so you have licensed by the state nurses giving ultrasounds?
Yes, sir.
Okay, thank you. All right, if I see there's more people who have decided to testify, which is great, fill the chairs, 2 minutes, and then we're soon gonna cut off testimony from in the room. We've got 3 people online waiting. So if you guys, ladies, would state your name and we'll give you 2 minutes.
My name is Linda Burt, and I'm a local Cheyenne attorney, and I'm going to be pretty brief on this. I'm not going to go into the issue of pregnancy crisis centers and their process or anything like that, because I don't think that's what this bill is about. I don't think it has anything to do with pregnancy crisis centers and what they do. I believe that Senator Scott mentioned the fact that there haven't been any problems in terms of localities or governments trying to take these rights away. And in fact, a 2018 Supreme Court ruling that came out of a California case said that they are totally protected in terms of their free speech rights, and they cannot be forced to provide any abortion information. That's not something they can do. They are protected by the U.S. Supreme Court for free speech. This is a unnecessary bill. The exempting any kind of nonprofit corporation, which is what this is providing special legislation for one kind of corporation, one kind of nonprofit corporation. It opens up a door for everybody to ask for special protections in terms of that. It's not necessary. All existing laws protect free speech in terms of their constitutional rights. If the pregnancy centers are operating in a professional and ethical manner, which certainly they have testified that they are, there is no reason to have special legislation for this particular nonprofit corporation. No other nonprofits get this kind of special legislation. It's an unnecessary bill, and I believe it's an unconstitutional special legislation in Wyoming. Any questions?
Thank you. Any questions?
Thank you.
Thank you.
Hello, my name is Michelle Summers. I am a licensed family nurse practitioner in the state of Wyoming, and I also provide a limited obstetric ultrasounds at Life Choice Pregnancy Center here in Cheyenne. Again, I wanted to reiterate that we don't do late-term diagnostic or identifying ultrasounds. It's just an early OB ultrasound that is, we get informed consent from each of our clients. And because we're addressing maternity deserts, pregnancy care centers should be protected by the state, especially when we're not asking for any money. It's at a no cost to the state government. And I just wanted to say that we are very clear in our literature, in our website, that we don't refer or do abortions. And it's clear on a number of pages. We take HIPAA very seriously and confidentiality, as we are required healthcare providers to get training on HIPAA and confidentiality when we get relicensed. And I believe some of the testimony was misleading. Nowhere in the bill are we restricting other agencies from the care that they provide. And we have pregnancy care centers located throughout the state where there is a lack of maternity care. So we provide a very good and valuable service to the state at no cost to them, and we're just asking for protection. Thank you.
Thank you. Any questions, committee? Thank you very much.
Hello, thank you, Madam Chairman. My name is Jennifer Ferrari, and I'm a physician assistant, and I am in Casper, Wyoming. And for the last 5 years, I've worked in an OBGYN practice. And I think what we need to do is, I guess I don't support this bill because I don't see that there's a need for it. I think one thing that I would encourage the committee to realize is that we've heard some repetitive testimony and some good testimony. It sounds like the Life Choice Center in Cheyenne has good checks and balances, you know, in order, but that isn't every pregnancy center. So I think we need to be cautious that we're not making a generalization that all pregnancy centers, all centers that give information to women with regards to pregnancy and their choices are the same. So I think that's one thing to be aware of. I think that more information for our OB patients is very important, but I think it needs to be information that covers all the choices and opportunities. For opportunities isn't the right word, but all the choices and knowledge that our patients deserve to have to make the correct choice for them. You know, we definitely want our patients to get good early health. I mean, I think that these centers aren't really providing maternal care as much as sort of an evaluation and some access to resources, and that they should be referred to our OBGYN clinics. And so when I look at this bill, I don't see that there is an issue that needs special protection, just as one of the previous speakers spoke about. I think that right now, those options are available. Those options are available for them to come in for a pregnancy confirmation test at OBGYN offices throughout the state. The difficult part is that there are becoming fewer and fewer of those, OBGYN providers in the state. So I guess I would ask you to critically look at, is there a need for this bill? I don't think that there is. And that we also should not blanketly assume that every pregnancy center is the same as the testimony that we've gotten regarding the Life Choice Center in Cheyenne. Thank you. And I would take any questions.
Thank you. Any questions? All right, thank you. All right, we'll go to online testimony.
Madam Chairman, the first individual we have is Denise Burke. Ms. Burke, if you could turn on your camera and unmute yourself.
Madam Chairs and members of the committee, I am Denise Burke, Senior Counsel with Alliance Defending Freedom. I have been asked to introduce and describe the Wyoming Pregnancy Center Autonomy and Rights of Expression Act, or the CARE Act. This bill was designed to protect Wyoming's pregnancy centers from censorship or discrimination simply because they do not offer, refer for, or counsel in favor of abortion, abortion-inducing drugs, or contraception. This bill prevents them from being singled out for this censorship or discriminatory treatment simply because of their pro-life ethic and practices. It does not, as some opponents falsely claim, make centers and their volunteers or employees completely immune from oversight. Unfortunately, pregnancy centers are all too often being attacked rather than affirmed in their mission. The number of state and local government officials attacking the life-saving work of pregnancy centers has grown exponentially over the past few years as the legal and political landscape surrounding abortion has shifted. Notably, since 2022, at least 21 states have introduced measures attacking pregnancy centers' autonomy and life-affirming work, and 5 have enacted such measures. By comparison, in 2021, just 1 year prior to the Supreme Court decision overturning Roe v. Wade, only 2 states considered such measures. This bill would allow Wyoming to be proactive in protecting the critical work of pregnancy centers and ensuring that women have the choice and opportunity to access the care, material support, and educational options they offer, both now and in the future. Thank you.
Thank you. Any question? Yes. Senator Scott.
Madam Chairman, 2 questions. One, where do you live? And second, are you aware of any Wyoming communities that have been abusing these centers? Because we do have a question as to the urgency of the bill.
I live in the state of Kansas, and I am not aware of any specific legislation or ordinances being considered in Wyoming, but that could certainly come up at any time.
Thank you. Any further questions? Representative Yen.
Madam Chairman, thank you. Ms. Burke, I apologize because when I got your written testimony, I was very confused. We have a Denise Burke that works in our Department of Insurance, and I thought she got a new job. And I thank you for participating virtually, so I know that you're not the same Denise Burke. My question to you is, we had a clinic in Wyoming that got burned to the ground because it provided abortions. Do you think that clinic, which had been under attack and literally physically burned to the ground because someone set fire to it, do you think that they're deserving of protections as well as these pregnancy centers because they're under attack?
They are, and they also are already protected under the Federal FACE Act and other legislation. What this bill does is prevent governments from taking action against pregnancy centers. So they are very different circumstances, but those centers that are facing attack, abortion, or otherwise do already have protection under the Federal FACE Act.
Any further questions? Thank you very much.
Madam Chairman, the next individual is Joan Brust. Ms. Brust, if you would unmute yourself, please.
Hello, Madam Chairman and committee members. I'm coming from a different angle. I live in Natrona County, not in the city of Casper, but that is my home. I am representing myself, nobody else. I want you to know of things that are happening in Casper that you may not be aware of. We do have an abortion clinic, and it is down the street from a pregnancy center. I'm very nervous, so I don't want to say anything wrong here, but it's not all kumbaya like they made it sound. I was a clinic escort, abortion clinic escort for over a year last year. I'm not doing it now, but what I saw coming from the pregnancy centers was not all kumbaya and friendly and sweet and kind. They had volunteers and employees harassing the patients that were trying to go to the abortion clinic. They would offer them flowers and prayers and sweet and kind words and everything, but they would also block their cars and try to get them to come down to their clinic, and just using deceptive practices. They had a giant sign about the reversal pill that the gynecologists and obstetricians have not even recognized it. They don't support it. It's not scientifically proven to work. And yet these people have a great big huge sign that says it's not too late. You can take this pill, which has horrible side effects. And I mean, I just witnessed all kinds of harassment for these women that they've already made up their minds of what they're going to do. And I'm sure they have done all the investigative work they needed to get to where they were going to be going into the abortion clinic. A lot of them weren't seeking abortion, but going for birth control. And yet these people would still harass them and chase them down. So I just wanted you to be aware of it. It's still happening in Casper. You can go up there any afternoon or every midday on like Thursdays, Fridays. You'll see them there. They're there. So That's all I got.
Thank you. Any questions from the committee? Right. Thank you very much for your testimony.
Thank you.
Madam Chairman, the last individual is Carlton Migliazio.
Great.
Hi, good afternoon, Madam Chairwoman and senators of members of the committee. I hadn't planned on making any testimony today, so I apologize. This is a little unprepared. But I did just want to note that during the testimony from the representatives for the pregnancy center down here in Cheyenne, that a lot has been made of being able to provide accurate information and good healthcare advice to women coming through their clinic, and a lot has been made that they are not discouraging abortion and that they are not avoiding it or in any way turning people away from it. And I just wanted to note that while they were saying that, I decided to go and look at their website. And as I looked at their website on the page on abortion, it goes through a pretty graphic detail of all of the various different complications and the way that that an abortion can affect a woman who undergoes one. It goes through a pretty significant detail about all of those complications and all of the potential problems with it. Under the pregnancy side, it mentions none of the potential complications of pregnancy and any of the potential complications of bringing a child to term. So I just wanted to make that note to this committee for all that we've heard about the balance of information coming from these clinics. Judging by their website, that certainly does not seem to be the case. And as we look at a bill that is looking to prohibit the state from regulating the information that they provide, I just think that it's as many people have said, an unnecessary piece of legislation. And also, I think that it is inappropriate to prohibit the state from regulating someone that has not been fully forthcoming in the way that they treat the information that they give to women in the state today.
Thank you. Committee, any questions? Okay. I just have one question for you. What would you list out as complications of a normal pregnancy?
So complications of a normal pregnancy, I guess I'm not entirely certain what your definition is of a normal pregnancy, but there are many complications that can arise throughout pregnancy. I have a cousin personally who has gone through 4 pregnancies, 3 of which have very nearly killed her. And each of those had to have various medical interventions, very invasive, several of which left her bruised, basically from the belly button down, and were pretty horrific experiences for her to go through. So I'll admit I'm not a medical expert on these things, but I am well aware from personal experience and from the people that I know that there are many potential complications from a pregnancy that can arise at any part of it.
Good. Thank you. Any questions? All right, thank you for your testimony. Okay, committee, it is now 12:25. We are going to have lunch down the hall and we will return at 1:30. Oh, and thank you. We're closing public comment on LSO, Draft Bill 26 LSO 136, the Wyoming Pregnancy Centers and Autonomy and Rights Act. Okay, be back here at 1:30.